That's fine.
Hello, good morning, everybody. Hello.
Welcome. Welcome, Prof. Good morning.
Are we there?
Good morning, sir. Welcome.
Good morning once again.
Good morning, sir.
Yeah, it's my pleasure to be reaching out to you guys once again today in continuation of our series of presentation as relates to management and assessment of low back pain. My hope is all those who are who we had lectures with last week are also participating this week. Because if we're having a new set of participants, then we're going to have a lot of issues. We have discussed a lot of things in the previous week, and we're hoping to build upon what we'll be doing today. So as much as possible, I'll be referring to some of those things we have talked about, and then we'll be building upon what we'll be discussing today. Well, today was supposed to be more of a hands-on, but unfortunately, due to distance and so many things, I think we have only one or two persons who will be coming in for the fiscal situation. But nevertheless, I will try as much as possible to use models to demonstrate most of these activities we'll be doing today. So if we have any concern as relates to the last presentation, please, we can bring it up quickly so that let's round up on that and then we start the business of today. Do any person have any concern or question or something you want us to talk about based on our previous presentation before we build on? Yes, please. Well, if there are no concerns, it tells me it's either we have understood everything or we did not understand anything. You know, the physiological law, it is either all or none law. It's either we have understood or we did not understand anything. But by default, I believe as physiotherapists, I know that we've grabbed all what is needed to be, you know, understood. So therefore, I will assume that we've understood most of what was discussed last week. I will be building up upon that today. So I will quickly share my slide while I try to take off the video to allow a good presentation and no distractions. Yes. So let me share my slide. Slide share. Where is it? Okay, good. We all see my slide? Is it visible?
Yes,
Let
it
me
is.
know if I can start.
Yes, it is visible.
We're already about 30 minutes behind schedule. Can we see the slide?
Yes, sir.
Yes,
All
we can
right.
see.
Thank you so much. So for today, our basic objective for today's workshop is we're going to wrap up what we started last week by defining and understanding the scope of non-specific low back pain especially in clinical practice, I will try to appreciate the importance of this special test in identifying the contributing factors to low back pain. Our hope was to gain proficiency because we are hoping that we will have participants on ground that will be able to demonstrate, because whatever we do, we ask you to come and do it. You know, you practice it, and then over and over, we know that the practice is likely going to make it perfect. But wherever you are situated, maybe you just need to get either your husband or your wife or one of your child or children to stand in as a my Zoom went off. I don't know. Can we still see the slide? Is it there? It's gone off. So I need to share the slide again. Okay. So sorry for the technical hitch. I hope the slide is back. So like I was saying, that we are expecting to gain proficiency in executing and interpreting most of these essential special tests. And what we hope was we should have participants on ground that will be able to carry out these procedures over and over, and they become proficient in it. So I'm trying to suggest that wherever you are, please get somebody whom you will be demonstrating what will be showing at your own point, so that you will have the opportunity to practice what we're saying, and then you give us feedback. Were you able to do it? Were you thinking there is a problem and all that? And you'll be much more happy if you have a patient in your presence. Don't forget, I said low back pain is a very common scenario. So maybe one of our spouses, our friends, somebody can have it around us. So you just bring in the person and you keep demonstrating with them. So I said we're going to also learn how to apply the test results that will help us to guide a safe and effective management program. So we need to know how these tests will interpret them to give us a good decision making in our clinical practice. So at the same time, you also build confidence that when you see a patient with maybe series of tests, A, B, C, D being positive, you know where to categorize this patient. Is this guy likely to be having a disc problem, or this patient with low back pain is more or less having what you call a stenosis? So you'll be able to know, as is this both tests, if they are positive at the same time, you have a situation where you have both a disc problem as well as a stenosis going on together. So all these are things we're going to be able to do by the end of today. So as a way of an introduction, we're starting with our low back pain. We want to go back and say any pain in our lower back which does not have an identifiable pathology, like we have mentioned last week, is said to be non-specific low back pain, because you cannot attribute it to a specific cause. That's why it is non-specific low back pain. We agreed that any pain that is localized between the 12th rib and the gluteal fold is said to be a low back pain. And we know from your 12th rib, you're coming close to your L1, and then it goes downward. So I said we categorize this pain, either you're having an acute pain, which is between 0 to 2 weeks, and then we move it from 2 to 6 weeks, less than 6 weeks. All these depend on the symptom the patient will bring for you. But at any point in time, a patient is presenting with a very first episode. That's the first time the patient is having back pain. So you call it an acute low back pain. Now, the moment the patient does not seek any care, as at that first time, to 6 weeks or less than 6 weeks, is still categorized based on what? Acute back pain. But imagine the patient had visited you, and then after 2 weeks, the pain went off, and then come back maybe 4 weeks or 5 weeks later, you're not going to say it's an acute pain still. Okay, but in general, the classification is said to be 0 to 6, less than 6 weeks is said to be acute pain. 6 to 12 weeks or less than 12 weeks is said to be subacute pain, while 12 weeks and above is said to be chronic pain. So we look at that as we move. All that, they have a reason why you must need to understand that classification and categorization so that it will inform what type of treatment you're going to do based on your patient. I said we must recognize that the recurrence of lower back pain is very, very common because patient will go thinking the pain has gone. So they go back to all those faulty habits, those faulty activities, so they can easily come back with recurrence. And of course, when you have the first episode of low back, the first thing it does is to switch. Sorry, we're still having issues with the Zoom going off and on. So I'm still going to share my slide back. We're really sorry for that. I don't know, we'll just fix it as we move. So I said we should know that back pain often it comes with recurrence, which does not have a clear structural cause. You won't know why the pain recur. So one of the reasons I'm giving us is that the first episode low back pain, even when you are now symptom-free, that is, you are asymptomatic, research has shown that most of your stabilizing muscles of the back are in hibernation. They are not working again. So if you go thinking because there is no pain, and then you continue your day-to-day activity, now because your spine is not stable, any little activity, just jumping in a pothole can trigger another reaction in the spine. So those are some causes which they term as back instability or core instability. Of course, we also have reasons based on the fact that many people, when they do not have that symptom of pain, they forget so many things. They go back to their bad habits, sitting habits, lifting habits that were not supposed to support the spine. And these are the reason why sometimes people go back to recurrence without their knowledge. Now, if you look at back pain, we mentioned that the prevalence and how it burdens us as a general population is that low back pain, even according to the most recent global burden of disease that is yet to be published. I'm just lucky to be part of the collaboration, and I know it, that low back pain still account for the highest disability in MSKs. Low back pain still account Well, we're very sorry. The network is not really helping us from this our end, but we're hoping to change to another network while we move. Nevertheless, we shall continue. Yes, I'm sharing my slide again. Yes, I hope you can see the slide at this point. I was trying to talk about the epidemiological studies we know already, and I said low back pain, according to the most recent evidence of the global burden of diseases study, you know, is still the #1 cause of worry among the MSKs that are presented globally. And it has been shown that the minimum prevalence is 60 to 90% among adults in their lifetime. And 60 to 90, what it means is for every 2 persons, 1 person must have back pain. Do you get my point? So that's 50-50. Now, if it's 90%, we're saying for every 10 persons, 9 will have back pain, at least at one point or the other in their lifetime. And I'm sure if you look at yourself and you will remember, you too, you have one episode or the other. So these are just the statistics that are very glaring and scary at the same time. Like I said, it is the leading cause of disability, and it has both direct and indirect economic impact. You know, when you have back pain and you cannot go to work, there's already loss in productivity. You know, you're going to have an issue where you cannot even play your role as the man of the house. A lot of roles, so many things will affect even the relationship between you and your spouse. So a lot of things that are related to back pain is there. So we say, of course, there are a lot of issues as relate back pain. When you have back pain, it takes you to both functional impairment, you have physical impairment, you have both psychological impairment. It's also going to bother on the quality of your life. All these are being impaired. So we need to look at it. Let's talk about the functional impairment that is associated with non-specific low back pain. Now, when you see a patient with a non-specific low back pain, one of the first things you're going to identify among them is what? The physical impairments. And in physical impairment, it means you are likely to see the patient having the reduced lumbar motion. When this will come, as the patient will tell you, I cannot bend my back. Sometimes as a Muslims, they say he cannot pray bending, he has to sit down and all that. So these are already affecting your physical being. Of course, you see your posture being distorted. When you have back pain, you'll see that you are standing awkwardly, sitting awkwardly, bending awkwardly. So your posture has been distorted. And of course, this will lead to also what? Your back fatigue. Any little activity you do, you will find it painful. Or you cannot move from one point to the other because what? There is a low back fatigue. You don't have the endurance to continue activity. Apart from physical impairment, you also have what they call the occupational impairment. This will mean the patient taking too much sick leave, they have reduction in your performance, and of course, your low back can push you into early retirement. You know, even when you are not retired, you are not 60 or 65 years, if because of low back, you just have to retire. So all these are the domains being affected, you know, functionally in an individual with low back pain. Another aspect is the psychosocial and emotional impact on low back pain. In psychological impact, they say the first thing that affects the individual, it becomes is anxiety. The patient gets into worries, you know, thinking about where will you know, how is it going to cope? Will this pain ever go? So that anxiety will begin to disturb the thinking and thought process of that individual. Because before you know it, it will lead to what you call the pain catastrophe or catastrophization. Because they start thinking that this pain maybe is in my kidney, is in my liver, You know, the thought process will distort the pattern even of the pain, and which will make the pain consistently there. Of course, the pain can lead to depression. Just imagine the story I gave you of somebody having a 3 billion naira project. And he was at the front of the project where the governor came to do a flag off of that project, but he could not come out of his car due to low back pain. You can imagine if the governor decided to cancel the project, that where is this engineer, or where is the consultant, or where is the project coordinator, or whatever. You know, that would have been huge for the patient. So we need to look at that. I said it can also lead to fear of avoidance. You know, the moment you begin to see that depression is setting in, your patient will have that lack of interest in doing anything, including movement or work. Okay? So it also have this aspect of social interaction. When you have low back pain, the first thing it does is to lead you into isolation. Because when you are depressed, what do? You just go and recoil in one side in your room. You don't want to interact with any person. You don't want to talk. You don't want to eat. So what happens? Isolation starts. From isolation, you mean that you're not going to play your role that you're used to play inside the family or inside the office. Do you get my point? So these will lead to role training. Since you are not playing your role, it means somebody will be suffering. If you are the one to take the water from the fridge to the table, now the water is not there. It means many people will not have water to drink is a problem. Just imagine that as the role you are playing. Now you are not there to fit into the role. So that's going to be a problem. And of course, you're going to have a disrupted support because we wouldn't know. The management will be saying that you're very lazy, you are not coming to work. So they don't see you as having a big problem that you need support. Or your wife, even in the house, will be like, what kind of a man sleep because of low back pain? Do you get my point? So many things will be distorted. Apart from the emotional and psychological domain, we also have the quality of life. Don't forget, quality of life involves both physical, psychological, social, and environmental. And I said in the social domain, one of the things you find out is that there will be restriction in mobility. Your ability to move from one point to the other is reduced. And therefore, this individual finds it difficult to move around. Now, when you don't move, it means you may not likely get all what you normally do and enjoy. So you're going to have problems with that. Now, because you have not been moving, what happens? Diffuse atrophy will set in most of your muscles, and that individual becomes easily fatigued. And of course, your sleep will be distorted because for the whole day, you have just been lying in bed. Don't forget, we say maximum contraction will lead to what? Maximum relaxation. If you don't go and do some activities, when you come to your bed, you may not find it easy to sleep off. When you get tired for the day, what happens? Sometimes you don't even need to lay the bed to sleep there. You know, you just crash into your bed. This is due to maximum contraction. So all these domains can be affected and it will affect your quality of life. Of course, the psychological part of quality of life in terms of your mood and your self-esteem, all will be affected. Whenever somebody comes, you know when you are sick in the house, the children will just look at your face. Nobody will ask you anything, they just go. You know, maybe they have something very important to discuss with you. Your wife will look at your face and she will just move forward. Now, a lot of things are going on that which you are supposed to know, but because of the mood you are in, your emotion, your face will express the problem. Even if they don't know it, they will just have to go away. So that's a big issue. It's going to affect your quality of life. Now, your self-esteem, it's also going to affect your self-esteem. Because why? You're seeing yourself as a man. How can a man now not be able to stand up and go and defend for his family? How can a man not be able to do ABCD? All that will begin to tell on you that, look, I think I'm becoming useless in this house. You know? So all these, we should also pay attention. Of course, the environmental aspect involves access to care and your finances. In the environment, If you have low back pain and there's nobody to drive you to the hospital, how will you take yourself? You see, that has affected you. Your quality of life will be reduced drastically. Now, apart from access to care, if you don't have the financial capability, imagine somebody who has to go out and work every day and make money before he can fend. Take just the laborers, the technicians and all that. They have to go every day, work on that day and get their money. Now, he cannot go work today. Who gives him money? You see, he has become a Masagi on his own. So therefore, we have to understand that low back pain can affect the quality of your life throughout. Now, what's the long-term consequences when we don't manage low back pain properly? There's a lot of issues that will follow. The first thing is that you have a patient with acute low back pain or subacute, and you do not manage it properly. It means you have just built a bridge for the patient to drag the problem into the chronic stage. So there will be chronicity in that situation. And of course, when chronicity sets in, it becomes something that will have to be part of the patient, sometimes even for life. You just have to learn how to live with it. And this is where we always have our challenges as physiotherapists. On our normal day-to-day clinic, our patient will only come to us after they have finished all the roundabout in GOPD. It's only these days, of course, with the UK system of the FCP, that's the first contact practitioners, you can have your first episode and don't go to the doctor and you go to your physiotherapist. But in our type of system here, the patient goes to GOPD. A patient with first-time low back pain, will they ever send them to physiotherapy? So it means who create the chronicity? This is the problem. Most of the patient we see, the patient can even be the one to prescribe painkiller for you. Your patient, they know the painkiller more than you. Because they have finished the whole shop of pharmacy shop of painkiller. Because the patient has spent a long time. The doctor keep seeing the patient and nothing is being done apart from X-ray, painkiller, X-ray, painkiller, and the X-ray is not seeing anything. You see the report come back as spondylosis, and he will think he should just continue treating spondylosis. With what? What will you treat spondylosis with? If it's spondylosis, it means a degenerative change. So how do you treat the change? So this faulty treatment is what leads the patient into chronicity. So therefore, when we have this kind of situation, we must make sure that we manage it properly at that early stage so that the patient don't have to cross over. Sometimes we used to feel as physiotherapists that we want to carry the whole, what do you call it? The whole glory on our head. But with low back pain, it's not like that. Do you know that some patients, even when you don't treat them at the first episode, they get well? We call it the instantaneous pain relief. With or without treatment, it has been shown that over 50% of persons with first episode low back pain will get better. So if a patient manages to come to you as physiotherapist, and after 2-3 sessions, the patient says the pain is gone, don't celebrate. Don't celebrate because it's not you. Do you get my point? There's an instantaneous relief. Whether you treat or you don't treat, that relief will come. But when should you treat? Your treatment should focus on preventing recurrence. Do you get my point? So that you will learn how to educate your patient. You learn how to teach the patient what they should do and what they should avoid. So that we don't even need to come to chronicity, not to talk less of they will start coming. Don't forget our patients, especially we in Nigeria, we have that notion since the pain is not there, why should I go to hospital? Don't forget, it is that pain that normally brings them to the hospital. Now the pain is not there, why should they go? Now, if you don't give your patient proper education about that problem from the first visit, you are likely also going to join the chronicity wagon. Do you understand? It doesn't mean if you tell your patient everything, you should not build them. Educating your patient, is it not a therapy? Is it not a therapy? So why can't you build your patient for the therapy? Because you as physiotherapist, you also think that until you put your gadget, test, shortwave diatomy, and everything on one patient. I entered the clinic once, I saw somebody, I want to give him shortwave, want to do laser, want to do ultrasound. I say for only one person, and for the same condition. That is when you will know that we are working. You know, it means we are also acting as a quad. If you are convinced as the physiotherapist, you have evidence that he doesn't need this, why do you have to go further to do? And it is not about the evidence base that will now come about talking about patient preference. Because a patient that you have not even given the modality before, how will he prefer one to the other? Is it not when you have used it, you say, I did that, I enjoy this more than that? It's because you have used them. So why use them when you know you don't need them? Say, I want to showcase to the patient that our clinic has. And in my own state of practice, I have understood from patients several times, especially patients who go abroad and come back. You know, when they go abroad, they will bill them like $100 per session. When you bill them 10,000 naira here per session, they will shout, just stand on your ground. Because you know what you want to give them. If you're billing a patient 20,000 naira, 30,000 per session, it's still way, way cheaper. Somebody who went to Egypt or wherever, bring you everything that he has done, MRI and all that, and they say he should come and continue his video at home. You don't have to ask him how much he has spent. You have to ask him. Only the plane ticket, you know, is more than 2 million naira. Not to talk of the hotel stay, not to talk of the hospital bills. Why then when you charge your patient 200,000 naira, it will be an issue? It sees you as a black guy like you. Now, if you start the treatment and then you're doing the right thing, you know what he will say to you? Mostly they will tell me, we know that the expertise for the job is here. It's just that it's those gadgets that we don't have. Will the gadget treat you? In computer, is it not garbage in, garbage out? If the whole shortwave diatomy is here and you put it wrongly on a patient, will the problem become worse? A patient with a pelvic inflammatory disease that is active with infection, you now put shortwave diatomy. Say, well, because the department bought a 5 million naira diatomy, we have to use it. Because, you know, the PID will mimic as a low back pain. So if you don't get a proper diagnosis, what do? You have created more trouble. What created the trouble? The enthusiasm to use a gadget. Well, it's simple thing. Okay, just do this, do that, do this test, and you'll be fine. Anyway, so please let's know the proper thing to do so that we avoid chronicity. Another problem when we don't treat our patient properly is that we decondition them. Conditioning means, for instance, if I want to play football and I've not been playing football for some time, or I've never played football before, if you run into a football match, you know this one that all these marketers from Kantengwari and everything, when they come back at night, they don't want to play 5-a-side. That's why every day, there's no day they will not pick injuries. Why? Their body is not conditioned for that game. You understand? And when you go to a doctor's office, your cholesterol is high. Please be exercising, be walking, be doing this. Is your body ready to do that? You have to condition the body. It means you train the body for agility, for endurance, for power, for strength and all that. That's condition. So when we now say deconditioning, what does it mean? We reverse all those gains. When chronicity is setting in, where the patient can move before he will not be able to do it. The things the patient can carry before he will not be able to carry it. The things the patient can endure before he cannot be able to endure it. So this is deconditioning. I hope we're getting it. So when chronicity sets in, it leads to also deconditioning. And of course, that will lead to what? Medication dependence. Because if he doesn't take a drug, the pain will never get relief. At the moment your patient becomes drug dependent, it means you are in trouble, you too, as the physio. Whatever you do, you say, you have not given me drug. Now, if you are treating a patient for pain, and then the patient is on high morphine, whatever you treat, what do you think will have reduced the pain? Is it your treatment or the morphine medication? It's medication. Because morphine is a high dose of an opioid that works in the central system. It blocks everything. So it means nobody knows the impact of your physio. Thus, the patient, and don't forget, it has a high tendency of addiction. And the moment the patient is addicted, there's nothing you will do. You remember when this sickle cell patient begin to take pentazocine? They do it themselves. And that is why in the US, that was the most commonest reason for HIV. That's self-medication of those pentazocine and opioid. Those drug addicts, they want to give themselves tramadol. And when they shoot tramadol, they go into every type of high-risk behavior. In fact, this guy, just like the way they smoke the cocaine, or smoke more and give me smoke. So he will use the same needle that somebody has used in his own. He too will use the same thing for himself. So why will there not be HIV spread everywhere? It was not due to sexual issues. So these are issues we have to be very careful with. Of course, when there is all this setting in, it will also lead to work disability. Your patient will not be able to go to work again. If you cannot go to work, what do? Who will pay you for your own service? Who will pay for your service? The patient cannot go to work. He can't make money. Any little bit of money he has is for him to eat and survive. So therefore, the patient is going from bad to worse. Okay? And of course, it said, when we don't manage this non-specific back pain properly, it leads to every type of comorbid risk. Why does it say comorbid risk? Like what? Colleague, please, you can speak. What are these comorbid risks we are talking about? Feel free to open your mics.
Hypertension. Spinal deformities.
Spinal deformity.
Yeah.
Hypertension.
Okay, we'll take it one at a time. Let's start with hypertension. Why do you think the patient will get hypertension?
Worrying because of the back pains can cause.
Yes, why do you think she will get hypertension, or he or she will get hypertension?
Because the heart
If
is not
somebody in
working well.
the chat box is thinking that we should please give more explanation about the conditioning. Okay, I will come back to that. Yes, someone mentioned that if we allow the patient, he will get the condition. So what conditioning we're talking about? Sorry, what is what do you think will the comorbid? You talked about hypertension. I'm asking you, what do you think will
The
have
person
led
cannot
to
sleep. The
hypertension
person will
because
not
your
be able
patient
to
had a low back pain that was not properly managed?
lack of sleep, hypertension.
So if you don't sleep, you get hypertensive.
Lack of sleep over a long period of time. Without sleep, when the person cannot sleep, the person begins to worry, and then that lack of sleep can also cause the blood pressure to rise.
Because
Okay,
another
thank
reason
you.
is
Yes, because
because
please.
due to inactivity, the heart are not working very well. So as a result of that, there may be accumulation of some clots in the blood vessels that supply the heart, and this can actually lead to turbulent flows of the blood going to the heart, and this can
Well,
attribute to
thank you very
hypertension.
much, Datumiwa. Yes, Tumishe. Thank you so much. I think I'm just trying to make sure we begin to speak like physiotherapy. You know, that somebody has a low back pain that was not managed properly, and the person can just have a comorbid due to that lack of good management of low back pain. The patient can begin to become hypertensive. But how? So this is how we're trying to find out that when you don't treat your patient properly, of course you have certain chronicity, the conditioning has taken place, the patient now has poor physical fitness, the patient has poor muscular activity, Now, due to poor muscular activity, even the heart function has been reduced. Okay? Now, because this heart of not just the heart function being reduced, the immobility of this patient will begin to give the patient the risk of what? Atherosclerosis. Atherosclerosis can break down in the blood vessels as plaque. And the plaque can go and jump into the heart to form an emboli. Now, when it's beginning to block the blood flow, the heart will need to work out. So cardiac output will rise. The systolic blood pressure will become what? Heavy. So this is all a process whereby this lack of movement, immobility, and deconditioning can easily lead to hypertension. The same way somebody talked about sleep, lack of sleep. Of course, if you don't sleep properly, it means your circadian rhythm is obstructed. Don't forget that insomnia, inability to sleep or to fall into sleep for a long time will lead to what? Depression. Now, the moment you become depressed, anxiety is setting, all you have to do, and that's where they begin to say, stop worrying yourself, stop thinking. Is that why you do not think? Already there's depression. So when you are in that state of depression, it gives you tachycardia. Your heart rate and everything rises. And before you know, the blood pressure, systolic and diastolic can also rise, leading to what? Hypertension. And that's why when you're already hypertensive, and then you have insomnia or lack of sleep, it's also another risk for your blood pressure to go higher. Do you understand? Yes. Yes. Some other comorbidities are what?
Spinal deformity.
Yes, somebody was saying spinal deformity. Is that Inyoma?
Yes, sir.
Good. She's telling us spinal deformity. Can you shed light? How could spinal deformity come around due to poor management of the low back pain?
Okay. Functional scoliosis. So when the patient is trying to manage the pain and they take like a position for a long period of time, it could be functional scoliosis from the low back pain.
Unfortunately, we are losing your connectivity. We can hear you very well. I don't know
Can
if
you hear me now?
If you can come close. Yes, we can hear you. Come close to your mic.
I said spinal deformity is like functional scoliosis. When the patient is trying to maybe reduce the pain or manage the pain, they take a
certain position, which at the long run will cause the lateral deformity of the spine, leading to functional scoliosis.
Well, I think what you're trying to say is one of the consequences of not managing properly. Because as part of your management of these patients with back issue is to ensure that you bring them into the normal lordosis of the spine. Okay. Now, if you fail to do this, to put up to the spinal lordosis because you are bothering about just reducing pain, then your patient is likely to have a deformed spine. But we're trying to come up with other comorbids which are not even related to the back. What are the other comorbids?
Hyperlipidemia. I think you've mentioned it.
What?
Hyperlipidemia.
Yes, hyperlipidemia. I think it's better we say obesity. You know, your patient is now sedentary. The patient don't move. It doesn't go anywhere. It doesn't hit anything. So therefore, if the patient, just sit in bed and eat all day, what do you think? They will put up unnecessary weight, and that will lead to obesity. And obesity has an array of other problems that is going to come up with for us. So I think obesity is key. We have to look at that. Okay? So, and that's why I'm saying there's a lot of comorbids. Yes, which other comorbids are we thinking about?
Neurological symptoms.
Neurological issues like what?
Paraparesis due to compression, maybe. Of course, poor management of
when you talk about
compression.
paraparesis and all that, those are not comorbids. These are other factors that are contributing to that back pain because we didn't manage it well. Do you understand? We're talking about comorbids that because you did not manage your problem, your patient well, all that type of diseases are entering the patient. And that's why we mentioned one type of disease as hypertension. Because how would you have thought that because you didn't manage your back pain properly, hypertension will set in? How could you have thought this because you didn't manage the patient properly, obesity will set in? So we're trying to look at the other comorbids so that we know them and think about them while we're doing the treatment to ensure that none of this sets in. Yes. Any other person?
Cardiovascular problem, like a
Muscular
myocardial infarction.
Cardiovascular problem is what somebody has mentioned as hypertension. You could say, okay, stroke is part of it and all that.
Muscular atrophy.
Muscular atrophy is also a characteristic of back issues. Okay, disuse. It's part of something I want to discuss under the conditioning. Somebody asked me in the chat box, so please, I'm going to go back to that as we move. But I want us to grab that issue of the comorbid because they should be at the back of our mind when we're assessing and managing the patient.
So financial
diabetes mellitus, beautiful. That's one of the things I've been expecting long ago. Why? It's the same procedure of obesity that is leading to diabetes. Because there is sedentarism. The body is not breaking down glucose as much as it should do. Okay? So therefore, the patient is likely to begin to have high sugar content in their system due to what? Disuse or immobility. So please, we should pay attention to this. Any other one?
Arthritis.
Arthritis. Thank you so much. Arthritis can set in. Okay? Because the patient is not carrying the body weight to go through the L2 vertebra as the center of gravity is falling out. Because of the pain, the patient will tilt. Therefore, maybe giving more load in the hips or to the knee or to the ankle. So easily arthritis can set in any of these major joints because more than enough weight is being transferred into those joints. Yes. So are we happy with this? Can we move forward?
Yes, please.
Yes, sir.
Do we understand now the concept of the comorbid risk?
Yes, sir.
Right. So let's look at a clinical reflection. I want to look at this situation of a patient. I said, I have a 45-year-old desk worker. You know, she's an office worker. And when I said desk worker, like a secretary, okay? The patient is avoiding movement. And over time, she has gained weight. And then she isolates socially. When I say isolation, if you invite her for a party, she doesn't go. You invite her for a ceremony, she will not be there. So there is a social, what do you call it? There is social isolation. Okay? So every social gathering, she is not there. Now, I want to ask you, what are the various domains that could be affected in this patient? Based on what we have learned before now. Yes, please. Alex. Somebody is starting with the social domain. Okay, I agree, social domain. In the social domain, what is it specifically that has been affected? And what is it, you know, under the social domain? We talked about so many things. Under social domain.
Her psychological aspect and her sense of well-being in the fact that she's obese, so she doesn't like people seeing her. She's I think the word is depression. She's depressed.
Yes. You said
depression.
That Rahmatullah?
Yes, sir.
I didn't get your point. Can you repeat it, please?
I said depression under social domain.
Social is not depression. It's psychological that is part of depression.
Psychological depression.
Depression is under the psychological domain.
Yes.
So that we don't mix them up.
Sorry.
Yes, there's a social domain. Somebody was trying to, when you mentioned social domain, and I said, what is it that is specifically been affected in this patient we are looking at? And he was trying to bring, you said depression, and I said depression is in the psychological domain.
Yes,
okay?
Yes, sir.
So now let's take it one after the other. I was expecting that you guys are following, and then you will take it chronologically the way I've highlighted them. I told you we start with functional domain. Under functional domain, we have what? Physical and occupational. Right? So under physical and occupational domain, what are the things that is affecting this, my desk officer? Yes, please, who will tell me? You know, this is how your patient will come to you. I don't always think that your lecture slide is there sitting down, and then you look at the patient and look at the slide. You know, you have to learn how to integrate those information. All right.
Reduce lumbar
and that's the reason why
motion.
I put that in for you to just recoil our senses of understanding based on what we have discussed. Okay, so we mentioned that we're going to have this. When you have back problem, it has domains that it affects in your life, and those domains cut across functional domain, psychological, and emotional domains. We talked about the social domain, right? And then we talk about the quality of life domain. I hope we didn't forget all this. So let's start with the functional domain. On the functional domain, I mentioned that you have both physical and occupational. So if we look at this woman I'm talking about, what are the physical problems based on the case? Yes, please.
Reduce lumbar motion.
Are you raising your hand?
One is reduced lumbar motion.
Emmanuel, are you there?
Postural control.
Okay, go ahead. Inoma, you can speak.
I said reduce lumbar motion.
I don't know what's happening. Is it my network that I can't hear you, or is the network from there?
I can hear you clearly.
Oh, beautiful. So Emmanuel, please go ahead. Yeah, I saw your hands up.
Yes, on that physical, reduced lumbar motion and poor postural control.
What is it in the question that you think is related to that physical domain? In the question I posted.
Yes, I
Avoid
said
movement.
Let's go back
I
to the
said what
question.
I said
If
I said one of it is
45-year-old
reduce
worker avoids movement, what's the physical domain there?
lumbar motion.
Emmanuel, you're far away. I don't know if it's the network or what. Can you
I
come
think I
closer
can
to the
hear.
speaker?
Okay, I said
Okay,
reduce
good. I'm hearing you now.
lumbar motion. Reduce lumbar motion and poor postural control.
Reduce lumbar motion. Yes, beautiful. Good. That's one of the major physical domain that has been affected. Okay, so therefore, we know that this individual is having issues with immobility. The patient doesn't like moving around, and that's going to be affecting our physical domain. What other domain do we think, what other part of this question do we think is part of a physical domain?
Poor postural control.
Poor
postural control.
Postural control. All right, I'll take it like that. So we move to the second aspect, which has to do with what? The psychological and emotional affectations. So what are the psychological and emotional factors that are associated with the problem of this patient? Who can highlight that?
I think one of them is anxiety,
Yes,
anger.
please. Let's look at the woman's case. What do you think are the psychological and social factors that are associated with her problem?
Depression and low
Let me let you
self-esteem.
understand that things are not in the question posted, but you have to infer. If somebody is having a social isolation, is that person not likely to have issues concerning anxiety, depression, and all that? So you must know that. Like I said, no patient will come and tell you, I just came to you because I am depressed with my low back pain. They won't say that. Okay, but you need to assess. And that's why we're trying to look at these domains one after the other. So there's a likelihood that the psychological domain that is affecting this patient has to do with anxiety, depression, as well as what? There are three subdomains under the psychological situation. Yes. What's the third one?
So,
I don't know if it's my network that is not making me to hear, but I'm happy that you guys could hear me. But I'm finding it really, really challenging hearing you. Inyama, you can open your speaker. Go ahead.
I said low self-esteem.
Yes, self-esteem. Because when the patient, even though don't forget that the low self-esteem, we discussed it under the psychological aspect of quality of life. I want you guys to be carrying all these things as we move. This is what we have been suffering in class. When we come and lecture, the students just want to pass exam and forget what we have done before. But this one is not about exam. We want you to integrate it into practice. Okay, and I always urge you guys, please don't register for most of this continuous medical education for the purposes of licensure only. It's for us to update our knowledge. It's for us to use it in our practice. Okay, it's not for licensure. I think the licensure just made it a mandatory aspect that look, as medical specialists, you guys need to update your knowledge continuously. And I believe anytime you come to this class or lectures, you will see that, oh, you have learned something new, or you've been reminded, or sometimes you've been able to shape your understanding of something. So please says, what are the occupational factors that is associated with the case we're talking about? Is there any occupational issue related to the case? I said she's a 45-year-old desk worker that avoids movement, has been gaining weight recently, and she isolates socially. Is there anything that has to occupy, that has to affect her job? Do you think there's going to be occupational affectation here?
Yes, yes, sir.
Yes, what is it? What do you think?
Number one, the patient will not be able to perform towards expectation in his place of work. Number two, due to that, he might be taking a consistent leave just to stay at home.
Excuse me. Michelle, I want you, when you speak, you should speak with reasons and evidence. She said the patient will not be able to work as expected. Why?
Due to the pain, and with pain, there might be some evidence of some muscle weakness, muscular weakness, maybe from the legs, because some of the nerves that control the legs is from the spinal cord, from the spine. So due to some weakness, the patient might not be able, not only the pain, so weakness can be some of the symptoms. So he might not be able to perform towards expectation at place of work. Then plus the pain too, the pain can actually limit ability to perform some activity that involve maybe lifting of patient, assisting patient to bed and the likes. Then secondly, the patient might the person might be taking.
That's very, very thoughtful of you. I really appreciate your judgment and reasoning. But I want us to understand that if you look at the question that was posed, it tells you that this patient doesn't like movement. Now, because she doesn't like movement, now it means lack of movement. Is it going to affect your job, or it will not affect your job? It will definitely affect your job. Now, as a desk officer, you need to pick up file from point A to point B. Don't forget, the secretary's job is get this file ready, move it to the boss inside, come back and prepare the file. Now pick this from that side, pick that from the other side, put them together, arrange this thing. Now that's it, your patient don't like movement. What happens to the file? It means they're going to pile up a lot of files that will not be worked upon. And that has reduced her performance. What will happen? The boss will begin to scream. And before you know, she's likely going to lose the job. Because the job owner doesn't know about it. He's not interested in your health. He's interested in the profit of his company. Do you understand? And that's why we should always know that your health is your own priority. The third party doesn't see it as their priority. The best they can do for is, we have NHIS, go to NHIS clinic. But our job has to be done. Do we get it now? Yes. Now, apart from these occupational related factors, what about the quality of life? The quality of life, I said, is divided into 4 domains. We have the physical. We have what? There are 4. We have forgotten. Physical, psychological, social, and environment. I don't know how I'm going to be carrying this thing to be putting into your heads, all of you, one by one. Maybe I have to be repeating over and over. Now, this aspect, the physical is still part of the immobility because the patient is not moving. So we begin to know there's reduced lumbar rotation, lumbar movement, and all that. Apart from back movement,
I can't hear you. No, begin. Network.
Sorry, it's the internet that is breaking us off. We have tried to change from one point to the other, but still the internet is not, is not cooperating with us. But we hope we just continue as much as we can get. Okay, so we've mentioned that we continue with the domains, which has both physical, psychological, and then social and environmental. Now, I want us to see what are the environmental factors that could affect the quality of life of this patient. Environmental factors, because every other factor we have talked about them. Environmental. It is accessibility. We talked about the health accessibility. Imagine that there is no anywhere she could get funding for her health. Imagine that for her to go to her office, she need to climb 3-story building. You remember the building of Federal Secretariat in Katsina Road? MRTV's office in let MRTV not hear me here now. MRTV's office in Kano's branch, the Kano's state chapter, their office is up and then 3-story building and the elevator is never working. So imagine that you are a secretary, that you have to go there 3 times every day. And now with your back pain, how do you go there? You see, they don't have to sack you from the job. You just have to sack yourself. Because there is no accessibility. Okay? There's also financial situation. What are the financial situation we can talk about with this patient? Yes.
Okay, I think the financial implication of this is that the person is most likely to lose her job because of the fact that
their job. Now, the little
because
funding she is having, she can lose the job and lose the finance. So
yeah,
it means she feels that the environment is not supporting her at all. So we need to understand all this, and definitely the quality of life of that patient will crumble and go down. Now, my next question for us is, what is the priority that we are supposed to face in dealing with this case? What are we supposed to pay attention first in trying to manage this patient? Please, any person. What's the first thing first? Kingsley, your hand is up. Okay, sorry, it's not Kingsley, it's King Alicia. Okay. Yes. King Alicia.
To increase the
Go ahead,
patient
open your
range.
mic.
Hello, can you hear me?
Your hand is up. Open your mic.
Yes, can you hear me? Hello?
Oh, maybe the person is not there again.
Hi.
She's speaking.
I think early intervention to prevent chronicity will be of importance to this.
Hello?
Yes, we can hear you. We can hear you. Maybe Prof.
Okay, yes, I said to increase the patient's range of motion.
I'm so sorry. Last speaker, I didn't get you because I lost connectivity. The internet is terrible today. Please, could you please recap and just give me a summary of what you have mentioned?
What I said was, they said the patient has like limited or is avoiding movement. So obviously to be to increase the patient's range of motion.
Okay. King Alicia said the most important thing we need to do is to work on her range of motion. Is that true? Do we agree with that?
Yes, sir, not precisely, sir.
Abdullah Suleiman, go
Yes,
ahead.
sir. Sir, I think sir?
Your hand is up.
Yeah,
Go ahead.
yes, sir.
Your hand is up. What do you want to say?
Yeah, I wanted to say, sir, I think the pain is the main driving factor and should be addressed first.
Yes. So you think it's the pain we should manage first?
Yes, sir.
Okay. You can bring down your hand. So any other person? Do we all agree that it's just the pain?
I do not agree.
Somebody said the psychological issue. Yes, please go ahead, make your own point.
Okay. I believe that the patient.
Is that Mr. Francis? Nelson.
Yes. I said I believe that the
Yes, go ahead.
patient problem is multifactorial, considering the fact that different domains have to be worked upon. In the area of prioritization, we actually have to do first and foremost education of the condition by letting the patient know how the various factors are contributing to her problem. It's in the line of the education that to get to know exactly what is happening to her. The pain knows that we'll be able to let her know.
Thank you so much, Mr. Nelson. I think I'm okay with what you have said. We don't need to go further.
Okay, thank you.
Mr. Nelson,
yes.
You don't need to go further. This is just what I've been expecting. You know, in our traditional physiotherapy management, we are already first and foremost the biomedical management. We always try to treat pathology. And I had told you in the last class that we should not be paying attention to only pathology. Okay? We need to look at the patient holistically and see what is it we will start with. And behold, what we should start with is to educate the patient in this situation that are contributing factors. Because if you educate her that, look, you're sitting in one point is what is going to make your pain worse. You know, she will begin to make effort. She will begin to adjust. She wants to do something, okay? Because it could be fear of movement, that she doesn't want to move and the pain will be more. Or the fear of her work, that is her work that is causing the problem. So I believe what Nelson has said is what takes us back to our what? Biopsychosocial approach. So you can see that the first thing we need to do is to go into a holistic approach. Look at the patient in totality, not about just being range of motion and all that, but what are those things we will think is being affected in our domains, and then we try to treat them as much as possible. So, I don't know, can you see my slide? No slide?
No, sir.
Okay. Yes. So, this is what brings us to our biopsychosocial perspective. And we must know that when we say itself a patient has a non-specific low back pain, I said you should know that it is not purely biomechanical. Like this, a lady mentioned to us that we should concentrate on our psychological issues, you know, but we should look at all these things all together at the same time, right? First of all, what is We're very sorry. I think after the break, we'll move from this venue to another venue where we think we'll get a stable internet supply. I think this venue is where we're having the issue, and the connectivity is very poor. So we may move to somewhere much more better. So like I was saying, I said the first thing we should know in our biopsychosocial perspective is that when you say it's a non-specific low back pain, it means it is not a back pain that is purely biomechanical. It means it is not one single cause that is there. And that's why we're saying, what do you think we should prioritize in this patient? And somebody said the range of motion, somebody said no, the psychological, somebody said no. But the best thing to do is we will have to relocate after the break to a better venue where we don't have this break in transmission. So it's quite worrisome because we start our discussion and then something breaks it again. So I said we're going to look at it in a holistic manner. We find out from the biological aspect, that is the pathology, between the muscle, other tissues, the disc. Where do you think the problem of the woman is? And of course, we talk about the psychological psychological factors. We want to see, is it that she's afraid? Is there a fear of movement or fear of work that is not making her to move? Because they said the patient does not like movement. And then what are emotions, her mood, you know, her self-esteem? What does she feel about it? We need to look at that and take care of it. And of course, we look at a social role. as a 45-year-old patient, how many children does she have? You know, is she the breadwinner of the family? Her parents, her children, the husband, how does she cope? Because there's going to be what? There's going to be a problem with her role participation. She may not be able to play her role fully well in the house or at work. And of course, what are the support systems does she have? Is her family there with her? Is the husband ready to support her? Is her institution or her workplace ready to support her? So I said, it is only this holistic care that can yield to a better outcome for the patient. Now, this stops where we are supposed to start our presentation for today. You know, after when we assess our patient with ODI and everything, we will get whatever we have said. Now, we will now plan her treatment. I said, for this case, there are implications for physiotherapy practice. What we need to do is we must set a functional goal. What do we mean by functional goal? When you say functional goal, what do you mean by functional goals? We all know goals, setting goals, right? But what do we mean when we qualify it by setting a functional goal? Yeah, when we say functional goals, you know, it has to be active goals. You know, it has to be a goal that is achievable within a time frame. Do you understand? So we must set that as a priority. We must educate our patients, and then we encourage them to do activity while we try to address whatever type of perception, beliefs, or attitude about that low back pain they have. We try to take care of that. And of course, we look at if there are reasons why we need to refer the patient. You know, it's part of your job. When you do a very comprehensive assessment and evaluation, you will know, are you supposed to treat this patient or are you supposed to refer the patient? What is the first thing you are going to identify that you know that this patient must be referred? What do you do? Any person? What is it that we're supposed to note first to know that this patient should be referred? Red flags. Thank you very much. Red flags. The moment you use your red flags and you identify this patient is, you know, is positive for those red flags, then your patient should be referred to the appropriate specialty. Of course, we should also educate on our patient on ergonomics, not just educating them. We also need to administer those ergonomics. It means the physiotherapist should be involved in trying to design a chair, a couch, a seater, either for the office or in the house. Unfortunately, because we are not actively engaged, even the government offices and everything, we just imagine our classrooms, the lecture halls. The physiotherapist must be contacted by the whoever is the what do you call them? Contractors, you know, to know what are the okay. So after this, we're going out. Economic, and then we have to teach our patient return to work. The RTW means return to work. You've treated your patient, it's just like in sport physiotherapy. You cannot finish treating a player and say he's well until that player can return to play. Do you understand? So your patient must return to work for you to know that you have completed the process. All right. Now, there are things I want us to understand that we need to discuss here. How do we balance pain and function among the
Yeah, function.
This has already put so many people into not having interest. You can't be breaking transmission at every point. I want us to discuss this. How do we balance the issue? You know, we mentioned that woman had pain, and then of course she has issue of functioning. And I was asking, how do we balance it? If we want to work on her pain, we may be missing her function. If we pay attention to function, then her pain is also going to be restrictive. How do we balance it? What do we do for this patient in trying to find a middle point between pain and function? Do we abandon her pain and concentrate on her function? Or we should abandon the function and concentrate on the pain? What do we do? He said we have to carry both at the same time. How do you do that?
Well, I think that the patient should be advised to carry out certain activities as prescribed within her pain level threshold. Because
Exactly.
if we should avoid pain.
Yes.
Okay.
Now, Nelson, that's just the most important thing here you have mentioned is the patient, that's what we call graded activity. The patient must do activities, but in a pain-free situation. Please don't always take that. There's one, I don't know if it's an adage or whatever, that it is no pain, no gain. Do you get that? It's not true. No pain, no gain. That is only pain that will take away pain. Is that true? We shouldn't do that.
No, not at all.
Because if any activity you do that will precipitate more pain. Yes. Hello?
Well, with you.
A function. Yes. Are you open to your speaker? Colleagues, please pardon us. You're going to just give us like 10 to 15 minutes to change the Wi-Fi of this internet connection so that we can start all over from where we are without distraction anymore. Please.
this one. It's a yes or no. Did I put this in my here?
Okay, Alex. Alex. Maybe run about. How much? Huh? I'll take 350 now. I beg.
Okay, enter my clear. Sorry, you can pass now. Sorry. Okay, say Calabar. Yeah? Yeah, Calabar. No, Allah, don't hear. I wonder. Não pode. Para mí guardar this Robson. But on the blink. Okay. Okay. Yeah, I hear you. I know. I'll tell you what day. What? Huh? Before.
Like, I'm not okay, I beg.
You're not okay. Come to front.
Thank you, brother.
Wani abu ne
Happy Joshua.
Get down.
Why is open? Enter now. Enter back. Open come up. Name up say enter back. What was something? Okay. 300. 300. 300. 400. Let me just say 300. That's 300. That's 300. No, like. Wait. Let's make a noise. Okay.
All right.
Mary, can we call the colleagues that we're back to a better presentation point now? We can now concentrate. Please, if you know any colleague that is participating, could you just highlight them to come up? We want to continue.
How much? All right, too much now. Huh?
Okay.
This is the price now. What of this one? No, it's too much now. What of this one? It's too much. Your last. It's too small.
That's true. That's the way you say. Just carry out.
Give me this three. Yeah, how much?
This selling
Can
them.
we start, or we just need to wait for some few people more?
One.
Yeah, yes, we are.
3. 1, 2, 3. 1, 2, 3.
Go on, we are with you. Go on.
And they come strong.
Let me just share my slide so that the other colleagues can join us.
No, it's still fresh now. It's not supposed to expire like this stuff.
Okay. I was saying that we're at a point where we need to balance between pain and function of a patient. What do we do? Do we concentrate in managing the patient's pain and leave function? Or do we go in trying to make the patient more functional and we leave the pain out? What is the best way to handle this scenario? What do we do? I want us to discuss.
Come
Yes,
again with
please.
your question, sir.
You didn't hear me very well.
Yes, sir.
I was saying we have a situation where the patient is having pain and then function of the patient is also limited. How do we balance managing the pain as well as the function of this patient? Are we supposed to pay attention in managing the pain and leave the function, or we're supposed to work on the function and leave the pain? Or how do we balance these two domains?
Well, I think the function will determine what is actually causing the pain. So we check the function. From the function, we can now start managing the pain. The function of the patient, then we can start managing.
Like the patient we presented earlier, we told you that the patient does not like to move around, doesn't like movement. Okay, now we don't know, is it the pain that is not allowing her to like to move? So are we supposed to just see that that movement is instituted and brought back, irrespective of whatever pain she's having?
It's going to be a synergic management on the background of holistic approach, whereby we advise the patient to engage in anything she's going to do based on her pain threshold, so as not to encourage anything that will exacerbate the pain.
Okay, that's the most important thing I want us to know here is we're going to give those graded activities. The patient must be encouraged to move, but at a pain-free scenario. We don't want the patient to move with pain. Do you understand? So I was trying to say we should not bear that adage that says no pain, no gain. This is not always true when it comes to management of individuals or persons with non-specific low back pain. So there are times that the movement must be in a pain-free situation. Are we together? Now, another point is, do we need to communicate effectively with this patient?
Yes, we do.
Now, if there is a need for an effective communication, how do we go about it? What, in terms of communication, do you need to pass to the patient?
Yeah, remember
your communication skill. Okay, go ahead.
The patient is from the description he's a 45 desk worker. So we need to check first of all, how long does this patient sit at a stretch? We also need to determine where the person sits, the posture the patient takes to maybe the walk, his or her posture while sitting. We need to educate the patient on posture management, ergonometric posture, and then encourage the patient, educate the patient why sitting for long, what it does to the back, and what the patient needs to do to reduce the pain. Remember, we initially said we don't need to tell him to stop automatically, but instead we can educate the patient. When you feel pain, stand up, move around, do some little exercises, and then continue what you're doing. We could educate them in those areas.
We agree we're educating our patient, but I was talking about how do we communicate effectively? I want to tell you what to do. How do you talk to somebody really matters. Imagine I just came to you. Hey, what did I do? But if I come to you, I started by discovering to you, in this life, we're born and we're born to die. In this life, this is born to end. I don't want the background to pass that information. But that information can kill the patient even before the patient dies. But the way you're going to pass the message is what shows how much the patient will be able to receive and accept you. Do you get my point? So what I want us to do, how do we communicate what we want this patient to do effectively? It means the first thing we should do is there must be no medical jargon. Please avoid big grammar. Don't say you want to there's a way that these medical people you used to use to oppress your patient. You want to build the patient. You see, you have this stenosis that comes with what are those people words there? You know, retrospondylolisthesis deprivation. I'm finished. Boy, you should. Because if you tell the patient you have the retrospondylolisthesis, what is the patient going to understand? Madam, the problem is you have inflammation. Don't you know it? Do you get my point? So what are we supposed to say to pass this message that this is the problem that is coming through, and this is how we're supposed to, attend to the problem or attack the problem. So, what is the most subtle? The first thing is you use a subtle language. You know, let me give you a scenario. Whenever black people move to America or to the Western region, what do they call them? When we from Africa like this, we move to Europe, what do they call us? Immigrants. We move from Africa to go and work in Europe, what do they call us? Immigrants. If a white man move from where he is in Europe and come to Nigeria or Africa to work, what do they call them? Expatriates. This is language already has shown that you
tourists.
Nobody likes me. Sorry, are you asking a question?
They call them tourists.
Hey, you said they won't call them tourists. No, that's when they come for vacation, that's when they are tourists. You know, but when they are working, they call them expatriates. It's the same thing, you know, if you are going to work in Europe, but they still call you immigrant. When they come here, they call them expatriates. When they see that you people are so many Africans, they call you maybe in fact they will say asylum. You know? So all this, when they come here, they say they are tourists. When we go there, they say we are this. The language has been set, you know, to eat up your self-esteem, to put you in a disadvantaged position. So you are not the same with them in their own position. But when they come to your place, they want to overrule you. So we must understand how language, if you follow the CNN, BBC, you will see how they, now, if an Oyibo man does something, they will call it, and who is an Arabic man does something, they will call it a terrorist man. It's the same thing that we do. Somebody bomb a whole people in a place. So they use the culture to tell you people. I said that language must be easy, understandable, and you don't talk more confusion than conviction. When you want to confuse somebody, use those basic grammar. All right? Now, we need to long-term goals. Like I said at the initial stage, that you're only setting a track for chronicity to set. Now, because we don't want chronicity to set in, it means it is at that moment we begin to set the long-term goal. And the fifth of our long-term goal prevent recurrence. Orange, you don't want this thing to come again. Another long-term goal is through ability to return to work. Instead of taking away the painkiller, what do you call it? The pain. It's about what? Ability to return back to her normal work so that she can function as much as possible. And then we also have a long-term goal of the individual becoming playing active role in the society. It's not just saying that the patient is okay. No, you should go back to be able to socialize. Don't forget she isolates on social function. So we have to work on all that. Now, ladies and gentlemen, we are going to the crux of our today's matter. And this is where we start from. For you to be able to assess any patient, you have got it class. we stay here? Can you listen if you can hear me now? Okay, you can now hear me? Good. So we're talking about the history clinical assessment, and I said we start with history taking. And I said you cannot do your history taking without making the first chief complaint, what the patient presents with. For instance, he's talking about pain in his low back. The moment he tells you pain with at the low back, you need to connect with the onset and duration of the program. Because if there is no onset or duration, you wouldn't have an idea of what kind of condition you are looking at. Is it an acute situation, a subacute, or a chronic situation? And of course, you should be able to find out where the location. Is the pain situated only in the back? Is it radiating to the lower limb? Is it one of the lower limb or bilaterally? Number 4, you also need to look at the character of the pain. Is it a pain only at rest or pain during movement? Usually when you have pain at rest, it symbolizes a chemical scenario, okay? It means usually a pain at rest is not mechanical. Mechanical means is when you do some activity, you feel the pain. But only when you want to sleep that the pain comes, it shows you it has a chemical affectation, which likely either a cancer-related cell pain or a pain that is due to affectation of one of the organs in the body. Do you understand? Of course, you should also look at the aggravating and relieving factors. In this part, I'm trying to tell us when we're taking the history of this patient. Don't allow the patient to derail you into telling you stories that are not connected with the primary problem. So you may have to be the one to direct the patient. Now, in this pain, where is the major site? Where does he go to? If the patient wants to tell you something about Zaria or somewhere, you bring him back. In this pain, where do you normally feel it? Is it at night or during the day? Is it when you are walking or when you are at rest? You find out the character of the pain. Now, this pain, what normally makes it worse? What relieves the pain? So those are the aggravating and relieving factors. Of course, during this situation, you also want to find out, have you had the previous episode of this same situation? You ask the patient that is history of low back pain. Have they been having low back pain before now? Including if it has it, what treatment was offered? And the treatment that was offered, were they effective or not effective? So that you have an idea, what is it the patient knows? You know, for instance, when patients, I tell you earlier, when they go abroad and come back, they will want to look at you as if abroad is the standard. So whatever you are doing, they are using the abroad information to assess you and weigh you. Do you understand? So the moment you begin to ask them what is the standard scenario, is either you begin to feel the patient increasing confidence in you that, oh, this guy is aligning to something, or you begin to change his perception that he thought it is those abroad that know what they are doing, but he is beginning to know that, oh, back home, you guys know what you're doing. So you change that with the patient. Of course, I said let's assess for red flags. Red flags are very, very important. You want to inquire about the symptoms or signs. Usually you want to know if there is a neurologic deficit. For instance, the patient tells you, I was working yesterday and, you know, suddenly I could not lift my leg again. You know, that tells you that the patient is having a neurological deficit. Or it tells you that before now, he could move this leg up, but now, the moment he takes it, the leg falls down. So that shows there's a neurological involvement, especially when the patient tells you before they were working well, and now recently he's beginning not to be able to hold his urine, you know? Or it tells you about cardiac anesthesia, that beyond underneath is feeling some equation. You know, these are all concerns that we must have to address. So when you see the patient tells you recently there is fever or sudden weight loss, or night sweat. All these are indications that there is one red flags. Apart from all these, we should also find what we call the medical, we used to call it in our class, medical and social history. Is that not? The patient is non-hypertensive and non-diabetic. The patient does not smoke or drink cola. He doesn't eat, he doesn't drink alcohol. But that's not what this should be about. Of course, we want to know what are these medical history. That is, has he ever been told if he has a history of cancer? You know, when somebody has cancer, it can be attributed to the present back pain, especially in males. If you say he has been diagnosed with prostate, you know, so that can be the reason why his present back pain is there. Of course, or any inflammatory disease, like inflammatory bowel diseases. When a patient tells you they have ulcers can radiate to the back. And most surgeons and physicians do not know that. You know, we should also know this, or previous spinal surgeries. These are all information you will need to collect from the patient. Now, the moment we do that, we want to also assess the pain. You have collected all this data. You want to start your assessment in terms of observation and evaluation. Is that all right? The O and E. Are we missing anything after family and social? Okay, sorry, that's what we are missing. After the past medical history, we said the family social history. Why is that important when we're talking about clocking of a patient with low back pain? Why is it important we should get the family social history? You want to know the social role of that patient, his occupation, right? In the family, which role does he play? Is he married? If he's not married, if he's a woman, you know, you want to know what are the social roles. If a patient tells you she's 45 years old, divorcee, will that send a message on what you should do separately? That when she tells you she's a married woman of 45 years old? Of course. Of her social role. She tells you that she's a divorcee. Do you think that is also going to contribute to her back problem? Please, anybody online, some physical guys here are not agreeing with me. Do we think that a patient who is a divorcee, somebody is saying they can still not hear me. Can you hear me, please?
Yes, we can hear you.
Oh, thank you. So I was saying that we need the family social history when we're clocking the patient, when we're collecting the patient data. So, and I'm saying, do you think you're going to have a different scenario of treatment or management if the patient tells you she is 45 years old divorcee and another one tells you she's 45-year-old married woman? Do you think those two information are likely to change your line of treatment?
Yes.
Emmanuel, go ahead.
I think looking at the divorcee,
yes.
she might be going through a lot of psychological trauma. So looking at that background, the family support is almost zero. And
thank you so much. I think that's where I want us to understand here. Even a woman who is not yet a divorcee, but she's having challenges in her marriage, you know, the perception of her pain is really going to be different. I've seen a lot of women that will come to my clinic. All why they came to the clinic is they needed somebody to confide in. A different problem. I once talked about a patient whom she had been telling the father of her son that the boy is into drugs. And the father refused to accept. So this woman will always come to the clinic looking tired, worried, And I don't have assessed and treated this patient that this pain is not what is happening. Now, there was a day I said, I need you to talk to me. You feel there is something bothering you more than this back pain. She said, yes, doctor. And she started narrating this, that boy is a 16-year-old who is just going to SS3, but met a gang because he went for boarding school, that he's not smoking and he takes drugs. She has seen him several times in his room, but she has tried to convince the father that they should take this boy for rehabilitation. You know, that the father is in denial. His son cannot do that. Please don't winch hunt my son. But I see the one of the son. Just imagine if maybe a second wife or someone talking about this. Now, because the father will not even see things the way she sees it, it's already a concern to the woman. So she came to me and she opened up. And this, you know the mildest thing I told her? I said, this is a simple scenario. That our teaching hospital now has a department in psychiatry for drug rehabilitation, especially for adolescents. She said, doctor, can you help me? I just made a 1-2-3 call with my colleagues and friends in psychiatry. And they told her, bring him tomorrow. Now, she took him there, did all the arrangement, and the father had to come and now agree that the boy will remain for 2 weeks rehab. You know, the third day she came back to clinic about the law, she said, I like I now. She said, okay, there's no problem. There's a body in something that is putting pressure on. So we must please learn how to pick up this information. Okay? So and that's yes.
I met a patient who was being managed for axial stroke and peristroke conversion disorder.
Yeah.
So in his history before I came, I saw she had issue with one of her sons.
Okay.
So when you see her presentation, emotion is not good. I was assessing how we are doing the treatment. And what do you want to achieve when you go back home? What are your needs? The first thing is to say you want to move around happily and the next thing you want to achieve when we come together and stay peacefully. I marked this point. But later at the end, one of the daughters said, she's so clean with you that even the psychiatry, the other specialist, the consultant, is not too open to you. She becomes more relaxed and free. I have to collect the phone number of one of the children house at Abuja. Definitely, there is a point with him. So he said we should stand with the phone number. So I said, well, I number because it's like the problem is coming more from him.
Well, somebody here is here with us in the physical class and is giving us a scenario that he has also encountered in his own clinic, where a patient was having difficulty managing the patient, and by the time he was able to interact with the patient, everybody was surprised that, well, how did you get to get close to this patient that even the psychiatrist could not get more information than what you were getting, and you know. Eventually, the patient opened up to him that she has a son who is also into drug and creating problems for the family. And our wish is for that child to get corrected. And of course, the fact that he could just give someone a few words and everybody was surprised on how the patient was participating actively in her rehabilitation. So these are just a few among others. I'm sure most of you also must have encountered one or two of such things. So it's very, very important, like I mentioned, we must discuss social role. So we talked about assessment. During assessment, we have mentioned pain intensity. We could use VAS, MPRS, and other scales. And then these scales must be measured and recorded. Another thing we don't normally do is the pain pattern. We should be able to ask the patient to describe the pattern. Is this pain constant? Is it intermittent? Is it always there? Or there's a specific daily rhythm that the patient goes through the pain? Sometimes it could be of the activities that we will catch when the patient is describing, there will be a pointer to what you do to take care of the patient pain. So please, let's assess for pain pattern. The same way pain radiation, we must try to identify if the pain radiates to other areas of the body or not. Because when it does, then we have to trace where the pain goes to. At this juncture, I want us to understand there is a difference between radiating pain and radiculopathy. Can any person give us an idea what's the difference between pain radiation or radiating pain and radiculopathy? Yes, please. Radiating pain and radiculopathy. Any idea?
No party. Hello? Yes.
Yes. Emmanuel, you're back again. Fine.
Yes, radiculopathy could be said to have no evidence, no medical proof, just like what we discussed about the non-specific low back pain does not have trace or identifiable factor why the pain is happening. But when you come to radiating pain, is a nerve affected pain that follows the nerve roots, or radiate to any part of the body of the chosen side.
Yes, Emmanuel, you are getting closer, but any other opinion?
Okay.
Radiating pain and radiculopathy.
Hello, sir. Okay.
Go ahead.
Radiculopathy.
Sorry, Ademu, you are. Hold on. Let Tumishe make a point, then you speak. Thank you.
Okay. Well, we're talking about radiculopathy. Radiculopathy is actually due to nerve injury, but in terms of radiculopathy, it's always associated with numbness, weakness, impaired sensations, and the likes. So, but radiating pain is majorly pain through the course of the nerves. So it's not always come with numbness, weakness of the limbs.
Okay, thank you. You're almost close to it. Yes, Ademu, you are.
Okay. Radiculopathy is a pathological affectation to the nerve roots. From the word radical. Radical is root, then pathy, pathological affectation. It could be a compression due to tumor, due to, sleep disc, disc prolapse and all of that. So some of the symptoms of radiculopathy include numbness, weakness, paresthesia, and radicular pain. So radicular pain is radiating pain. It's one of the symptoms of radiculopathy.
Okay, I think here I need to make it very clear that there are three distinguished groups of pathology we're talking about. You must know that there is radicular pain, there is radiating pain, then there is radiculopathy. Tumishe was almost able to capture all these, but intermingled with them. So can we start with radiculopathy? Tumishe, can you come back? What do you call radiculopathy?
I said radiculopathy, it could be due to the nerve compression, but normally the symptoms.
What is the radiculopathy? That's what
radiculopathy. Okay, radiculopathy is when there's weakness in the lower limbs, numbness, impaired sensations.
Beautiful. I think that's when I just want you to stop. Radiculopathy is not a pain. It is not pain related. There are sensations that affect a nerve root. Okay, radiculopathy are sensations which will come with either sensory sensation or motor sensation or motor affectation. So in the sensory affectation, that's where you have paresthesia, numbness, and all that. And while in the motor affectation, that's where you have weakness. Okay, those are radiculopathy. So it is not a pain. Okay, then we have what we call the radicular pain. Radicular pain is that pain that emanates from a nerve root. You know, it traverses the nerve root. For instance, a patient telling you, I have pain. That's why you have to be very sure. It's touching the upper part of the thigh. You know, just on this side, he's telling you, I have pain on the anterior aspect of my thigh. So you have to know that if that is a pain, the patient, you have to be sure. Is it a sensation or a pain? You have to ask the patient to clarify. So if patient tell you it's a pain, then you now start to ask, is it a burning type of pain? Is it a pepperish pain? Is it pins and needles? Is it a tingling? You know, so you need to know, is it a sensation or a real pain? Because we don't have any objective measure that we can use to counter the pain. If the patient is a pain, then you call it radicular pain. I don't know if we're making sense. The last one is the radiating pain. Radiating pain means a pain that is emanating from other organs in the body. For instance, somebody having pain in the shoulder, perhaps is radiating from the heart. Do you get my point? Or someone having back pain due to a pain in the prostate, inflammation of the prostate, or pain in the back due to inflammation of the bowel, your GIT. When most patients with ulcer, they come to tell you this pain, this, so those are radiating pain. I don't know if I've made this clear.
Can you come again, sir, please?
That's the bad pain. Sorry. And you said I should come again?
Yes, sir, please, sir. Sorry.
So we started with radiculopathy, just like you accurately mentioned. Radiculopathy is not a pain, rather a sensation that will affect either the sensory or motor aspect of a nerve. Okay? And it could present as either a numbness or paresthesia or other sensation, but it is not a pain. Is that one clear?
Yes, sir. Yes, sir.
Then we talk about the radicular or radiating pain. The radicular pain is when the patient complains a pain that travels through a nerve root. And that's why we start talking about what type of pain. Is it a burning pain? Is it a pepperish pain? What are the characteristics of that pain? Then the last one is the referred pain, which we say it is a pain that is coming from other organs far away from where the patient is pointing to his pain. Like, for instance, a referred pain from the heart could go to the shoulder. Okay? A referred pain from the, the prostate can go to the back. It's being referred. Inflammation of the GIT can give you pain in the upper back or lower back. Those are all referred pain. A patient that is having PID can also refer pain maybe to the SIJ. All these are all referred pain. So instead of you going to manipulate the SIJ, why not just go treat the referred situation and then the pain will disappear? Trinisha, is that a bit clear?
Yes, very clear, sir. Sorry, sir, I have a question before you go. I don't want to forget.
Yes.
I'm currently managing a patient now. So the patient has a lung cancer. So now, before the patient was diagnosed of having cancer, I've been managing the patient of having low back pain, SIJ. So now, the patient, after the whole thing, the patient was referred again. Then I found out that he was diagnosed of having lung cancer. So now, but the where he was having the pain is not the usual side. So the pain now is exactly at the low back now. So now I don't want to get mixed up. So how can we, in that scenario, how will I be able to know that the pain, because of the pain, is not a recurrent pain or is due to this recent diagnosis of lung cancer?
Well, your recent diagnosis should be able to tell you if there is a metastasis. If the cancer has metastasized, then you cannot rule out that it is not a cause of the low back pain. Do you get my point?
Yes, sir. Yep.
But if there is no metastasizing of the cancer, it's just situated at the upper lobe or there in the lung, so you cannot attribute that to the low back.
Perfect. Thank you, sir.
All right. Is there any other concern? Can we move forward?
I have a question, sir.
Okay, somebody on physical is asking. I will return back to you.
Okay.
Yes. The person on the physical side is asking, what about when patient tells you, I have a pain in my back, and that pain is radiating to the lower limb? What are we expected to do? And that is the reason why we're trying to clarify today, that you should understand. Is it because the patient will just try to tell you it's a pain. Do you get my point? Because he knows that something is bothering him on this side. So you will need to assess and be sure. Is it a pain? Is it the same thing you are feeling in this back? Is it the same thing you are feeling down? The patient can tell you, no, yeah, I'm just feeling something, you know, nyam, nyam, nyam. Or I'm feeling my leg with the sand and something like that. You know, they have different way of describing those sensations. So, but if it tells you the same pain I'm having in my back, it's the same kind of pain I'm having here. You know, you have a radiating or radicular pain. Do you get the point? Yes. Yes, please. Who is online?
Okay, sir.
Yes.
And my question is a radiating pain same as a referred pain?
No. I mentioned that referred pain are those pain that come from other organs away from where the problem is, the patient is complaining about. The referred pain follows an embryologic connectivity between an organ and that aspect of usually the back or the upper back or shoulder. And I gave you an example like the heart. There is an embryologic connectivity of the nerve roots between the heart and that of the shoulder. So patient can usually, when they have what you call myocardial infarction, you know, they start telling you like they're having pain in their shoulder, and then they will point to their chest because there's a connectivity at the embryologic state between those points. The same thing between the prostate and the low back. There's a connectivity, embryologic connectivity. So those are referred pain. It's coming from an organ, okay? While the radiating pain is coming from the nerve roots. So it's a pain that travels through that nerve root that you call a radiating pain. But radiculopathy is not a pain, rather sensation or motor weakness.
Okay, sir. So it means
Okay,
that
yes.
So it means that radicular pain is same as radiating pain.
Exactly.
Okay, sir.
Yes. So I know that we have always been mixing up all this together, and that's the reason why I'm trying to make sure that we get it clear at this point today. Okay. So can we make progress?
Yes, sir.
Okay.
Just a question, sir.
Okay, go ahead.
The pain, maybe the referred pain of ulcer to the shoulder. What can you clarify that to? Is that a referred pain or a radiating pain?
Of course, it's a referred pain. And that is why it has a chemical connectivity between the GIT and the shoulder. Basically, what happens is when you have, increased gastric juice, the acidity of the stomach will increase, and it begins to deposit through those embryogenic connectivity between the back, shoulder, and the bowel. So that's basically what happens. And that's why patients get it difficult to understand this pain. Is it really a back pain, a chest pain, a shoulder pain, or is from the ulcer? But when you're dealing with this situation continuously, you get to understand how to delineate between, peptic gastritis and a mechanical pain in the back or shoulder. So I mostly, when patients come like that, you start from the history. And if the patient tells you they have ulcer, all you needed to do is to just ask them to go do some quick H. pylori test, which can confirm that the patient is still having the ulcer bacteria, which needed to be cleared. You know, after clearance, you know that if the back pain and whatever has reduced. And of course, if it's a mechanical pain, usually movement can provoke the pain. And then you have movement that will reproduce the pain. But with those referred pain, movement does not affect the pain at all. So those are some ways you can take care of that. Yes.
Thank you, sir.
Can we continue?
Yes, okay.
Okay. Yeah. So I was talking about the pain radiation, and I said we also deal with the alleviating and aggravating factors. That is, basically, if it's a non-specific low back pain, you want to identify from the patient. Your patient is the key, because it's not a spiritual healing. Now you say, you don't need to tell me. I know what is wrong with you. I will just do for you, you will be well. No, you need the patient, because it's the patient that will give you every tip that you use to take care of the patient with. So if the patient tells you, basically, whenever I lie down with my leg this way, my pain is relieved. You as a specialist, you already know the position she's demonstrating, that I think this position takes away function of the sciatic nerve. So therefore, you are going to have freedom of movement. Or no, this opens up the disc space. You're going to have good movement. So the moment she tells you is what I do that I relieve my pain, it means when I want to treat, I will do more of my treatment using that pattern. That's the secret. Do you understand? Because anything that aggravates the pain, you treat to avoid it. If the patient tells you anytime I try to bend my back, that's when the pain is. So why will you be doing flexion treatment for the patient? You know, you're going to provoke more of the problem. So the aggravating factor too should be explored so that we know what are the things that exacerbate her pain. Is it a specific motion or specific position? We want to try to see what are the associated symptoms. Are there other additional problems that accompany this pain? So that's what we're talking about, the tingling, you know, different sensation, not just only the pain. We have to look at it. Now we begin to look at what has this pain in her life or in the person's life. What is it impacting? You know, we have mentioned in our previous slide earlier, told you, you know, we have what we call the functional impact of non-specific low back pain on our function. You know, we have on our psychological and emotional well-being, and we have that on our quality of life and all that. So we have mentioned that. So we try to see how does this pain affect the patient's activity for daily living. For instance, if a patient tells you, I find it difficult to stand and wear my trousers. You know, that's to tell you that this pain is worrisome. Just because wearing the trouser is an activity for daily living. When the patient cannot wear his trouser, that's a big trouble. You know? So we must understand that his work, his sleep, and overall quality of life. So you go back to my slide of the earlier morning, what we've talked about. I said the psychological factors will also evaluate emotional and psychological well-being. And then how does the patient perceive this pain? You must try to understand, you know, the patient's beliefs, his perception, and attitude towards this pain. If you don't know it, for instance, I've seen a patient before. I told you about the story of the guy that I said he got 3 billion naira project. Do you know that when I was treating the patient, a relative of the patient came to me and said, "Doctor, do you know that it's a spiritual company?" He said, "Don't let him know that they have already consulted one malam or whatever spiritual leader that said there are 2 people that are involved. You see, they will set you up with enmity with other people. They didn't want him to get that honor. So therefore, they wanted to scatter it at that point. A spiritual leader that you have just brought lunch for him, the guy will finish you straight. You know? So he said, that's spiritually. I said, if you just continue what you are doing. I said, thank God this day you should take him away. Because it will have been a big problem. That he is going to fix it from where he is. I said, I'm happy with that. Hey, I said, I'm happy with that. I didn't say you should take him away from the hospital. Now, after 3 days, I took the patient for MRI because the pain was huge. I allowed inflammation to go down, and the patient could now stand and walk. After we took him, the thing came out with about multiple levels of decompression. And somebody is telling you that there's one father or brother there that doesn't want you to succeed. So we must understand patient's perception and beliefs about the pain. Very, very important. Of course, we should also look at the history of his medication and treatment. Because if a patient is already used to maybe injecting themselves, addicted to some drug, the patient comes to you, not any NSAID that will work. Which NSAID do you want to give? He has finished himself with tramadol, you know? He's used to tramadol, he's used to pentazocine, you know, Petidine. Most of these opioid drugs he could give himself. So what do you want to do for such type of patient? There was a time they took one of patients of mine to the theater. The anesthetist told me that the guy had a fracture. He now said they gave him about 300% of the normal dose of the anesthetic agent. They call it Marcaine. You know, they use it to anesthetize is what do you call it? Local anesthetics. It's not a general anesthesia, that spinal anesthesia, so that the patient can be awake while the surgery is going on, since it's a lower limb surgery. Now they gave him the first dose, second dose, until they gave him times 3. And whenever the surgeon caught, the patient would say, the GO. That is too painful. And you know, after they gave him the anesthesia, they will tell him, lift your leg up. The guy will carry him. Yeah, but that is a consultant anesthesiologist. Dr. Atiku called me and said, hey, Wajiri, this patient you sent to us, I'm sure it's a normal patient. He said, I'm giving him 300% for that normal people. But if they ask him to lift your leg, he will lift the leg. So that when they caught the patient, the surgeon now said they should just go ahead. The patient is not feeling pain. So they went the first tissue, second layer of tissue. The moment they got to the tail, like, hey, you want to have enough with you on the regular one. He said, two people go and find something. Of course, I could feel the muscle contracting. So it's not relaxed for us to move on. Yeah. So they gave me a call. I came to the theater. I now asked the patient, before now, what do you use to smoke? He doesn't smoke. He only took himself injection. I said, what about injection? Another I said, trauma. I said, where do you buy trauma? He said, people used to bring your body. I said, why do you use trauma? He said, if he doesn't use trauma, he will never be well. So you can imagine the surgeon that wants to do the surgery for him did not even take time to evaluate and understand that patient. See what they suffered in the theater.
They just open their door and look at you.
Yes. It was only then that the anesthesiologist went back and get something bigger. And realized that before the guy was given an overdose, I had to sleep. But the surgery to be done. So we must understand these things are realities. Okay?
8 years ago,
yes,
I accept one old biologists from all the anesthetics he used to take. Yes. That's the beginning of all his problems. He cannot even walk at all.
Because you have to stop the drugs.
Because he stopped the drugs. So he has to take it back.
Go back. So you can imagine. So it's crazy. Crazy.
From there, I stopped seeing patients that have been prolonged on.
To stop. You don't know that. How you do they call withdrawal syndrome. Yes. You can't stop at once. The patient will collapse.
Yeah.
You have to be either reducing dose or reducing, this is how you go about it. Now, I said in physical examination, we have to start by observing the patient's posture, their gait, their overall appearance. We want to see, when we see the patient presented with no obvious distress of pain or respiration, is by observation. Okay? Of course, we have to evaluate the patient for range of motion, of course, of the spine. You want to see forward bending, extension, and all that. You want to know how much lateral flexion and rotation the patient can do. Of course, we should palpate the lumbar spine and the paraspinal muscles to be sure there is no spasm. Because when you palpate the muscle, you will know if there's spasm. Spasm means reaction, of the muscles to the tissue. If you want to manipulate a muscle and you see that the muscle is pushing your hand back, you know that there is spasm there. Do you understand? Because maybe we should just call it tenderness. You understand? So I will understand it very well. Spasm means tenderness. What it's defined is a resistance to any movement. Okay? Of course, we're going to do palpation, then we go to the neurological assessment, where we perform comprehensive neurological examination, including muscle power testing, reflexes, and sensory function to the extremities. Of course, we're going to do the SLR, and then we'll see the different one. All this, we're going to do it when we want to talk about our special and essential test. We have slump
Hello,
test.
sir. I have a question, sir.
Okay, let's go back. Yes, go ahead.
Sorry, sir. In regards to the range of motion, for instance, we are dealing with elderly patients that could not they could not walk without hand aid. So, what's the suggestion in regards to having their trunk range of motion to be assessed in standing? Is it advisable for us to do the trunk movement, like trunk range of motion in sitting? What do you think, sir? Hello, sir.
Can you hear me now?
Yes, I can hear you now, sir.
Why are we going to assess him for that? Do you get my point?
I didn't get you, sir.
A patient, yes. You said?
I didn't get your point, sir. What you just said, the last thing you said.
Okay, yes. I was trying to tell you that for you to assess maybe for your elderly patient in standing, it depends on the discretion based on other activities you have evaluated. Assuming you are looking at an 80 or 90-year-old man whom activities do no longer need him to bend or extend the back. Most of his activity are in sitting aligned position. Why do you need to put him into standing for assessment? So if you know that the patient does not need that, then you don't need to evaluate it in that situation. And don't forget, there's a risk of patient fall at that age. So if you put him into standing and he's going to touch the toes, the patient is likely going to fall forward. So with that, it is more important you put them in assessment in lying position or sitting position, because you can assess for back flexion in a sitting position. The patient can just sit in bed with the leg into extension, then you put them to touch the toes. So that's also a flexion activity which is safe for the population you are dealing with. I don't know if that helps.
That's it, sir. Thank you, sir.
All right. So, I was saying that other physical examination we are going go into our specifics, the essential test. Before we get there, I want us to know that apart from looking at functional assessment, which is all about bending, lifting, walking, and of course, to check for if there's any deviation or pain trigger. That's the essence why you have to do functional test. Functional test means you want to see how functional your patient is. Especially you want the patient to bend. Can she bend forward? Can the patient bend into extension? Can the patient reach something that is slight flexion or lateral rotation? So all this is to see, is it that when they do the movement, it comes with pain, or it doesn't come with pain? Or when they do the movement, you want to see that is the range of motion restricted or not? Now, you will do all this and then you go for more of your provocative tests. Those tests that are supposed to reproduce the symptom of the patient. A patient that tells you, I have pain in my back, especially in this and that. You want to ask them to do some movement, that will show you that this is how the pain comes. Now, those provocative tests are supposed to specify where the problem is coming from. Especially if you do what they call the quadrant test. The quadrant test will tell you, is it more of an facet joint arthritis, or is it more of a neurological claudication, that is spinal stenosis? Do you get my point? So we'll be able to do that. We'll see it as we move. And I'm trying to say we also need to do spinal alignment where we check for lordosis. Is your back straight or is not straight? Do you have some deviation like scoliosis or kyphosis? We're going to check all that. Now, the most important thing I want us to consider is the dermatomal supply, because we talk about radiculopathy. If you don't understand your dermatomal supply, you will not be able to trace and track the pain from where it's coming to or where it's going from. Let's look at this chart. I have a chart that talks about your disc connectivity, the nerve root, where it's coming from, and then the radicular pain, to which region it goes to, and then the radiculopathy, where it goes to, based on specifics. The people online, can you see the image?
Yes, sir.
So we can see it very well.
You can see it. I don't know if I can enlarge this way. Is it better? Is it better like this?
Yes, it's okay. Yes, it's okay.
All right. Now, I want you to look at the nerve roots, where they are emanating from, and then where they're supposed to go specifically in our body. Now, I've captured between L2, L3, L3, L4, L4, L5, and the L5, S1. We're going to see all that. So, we should know that when you have a disc problem or a nerve root being compressed at between L3, L4 disc, you will see that if there is a radicular pain, it goes towards the lower back. You see it from behind, just like where you are used to putting, for the men, where you put your pocket, the wallet, where you put your wallet. If you put your hand just especially where you put your wallet, that is where L3, L4 nerve root goes to. You see, I did not bring L1, L2. Why? Because it's always in front. That's why the femoral nerve. Do you understand? But from L3, L4 is where you have these sciatic issues. Okay? So I said, if the patient is telling you, I have pain for my buttocks this way, it doesn't go to the leg. It tells you just this buttocks, your pocket region for a man where you put your wallet. It tells you that is more of a compression between L3, L4. Now, if it's a sensory issue where it's a radiculopathy, the radiculopathy will be pointing towards the anterior medial thigh and knee. When the patient tells you somewhere here, you know, close to where you have the quadricep tendon crossing into the knee, you know, those are the regions that is affected by the pain. So anteromedial region of the thigh. Now, if it comes with radiculopathy with weakness, the muscle that will be weak is more of your quadricep muscle. Okay? So what happens when the quadricep muscle is weak? No. So extension becomes a problem. You see? So you can see that you're beginning to capture your patient with a good idea in the brain that this is what is going on and this is where you should be targeting. Are we together? Now, of course, when you are looking for an atrophy, it's going to be on that same muscle that is not working. So please, I need us to go with this knowledge of this slide today. I don't know if you're going to cram it, you're going to watch the allo and put in your head, but this is very, very vital for any person who is going to be managing low back pain. Yes, you can print it and paste it in your clinics. In your room, in your clinic, this should be one of those things that you are used to managing low back pain should not go without at every point in time. This is going to save you a lot because these are the things that most of the surgeons are not paying attention, that they keep wasting patients' money for MRIs. Yes. Because if your clinical scenario have demonstrated all these things to you, you don't need an X-ray, not even an MRI. Okay? So, and now if the affectation is between L4 and L5, you now see where our pain is crossing to. You can see between the sacroiliac joint, you know, and it goes down through the hip laterally. Just as if you are talking about the TSL, the tensofacial letter. It goes through that scalp. And if you treat both with back pain, this is a very common affectation because L4, L5 is the region that is the most place that takes the pressure of the weight of the body. So most patients are likely going to come with that complaint. Okay? And that is the pivot where the movement also takes place of bending and extension. So you can easily see where it can be easily damaged. Yes, the common site of damage. So you see it there. They said the numbness, usually, it goes through the lateral leg and web of great toe. So you can see that it affects only the big toe and maybe somewhere close to the big toe. You see? So when a patient tells you this side, no, he will tell you this side, I don't feel anything in this, but this big toe and here, they can hold these two for you and tell you, I feel something that I don't understand what it is. New, they don't describe it in any pattern. So that tells you that the affectation is coming between L4 and L5. And they said if the motor affectation is there, you find that the patient cannot dorsiflex. Okay? And this is why it is very common. After any surgery at L4, L5, your patient will lose dorsiflexion. My people online, I hope we are following. It's like the physical guys are taking my attention away. Hello?
Yes, sir.
We are following. All right, thank you. So, and they said the atrophy is usually not really appreciated. It's just a minor loss of muscle. You will see there, it is not really a problem. So, when the affectation goes between L5 and S1, you now see how it cuts through the medial aspect This is one also a common scenario we see in our clinics. You see, it goes through down, it does about the pain, straight from the buttocks all through the back of the thigh. It goes just like the sciatic nerve cord. You see it? It goes all through down. And then for the sensation, is usually at the back of the calf muscles and then to the little finger. So when patient tells you this little finger is where he's having issue, then it's also a concern for us. And of course, so it's we said that there is an affectation usually at the plantar flexion of this patient. The patient will not be able to stand on their toes. Stand. So whenever you are thinking the problem is between L5 and S1, and patient is really telling you that this little finger is also disturbing the patient, so just ask them to stand on their toes. So you start to see that plantar flexion becomes a problem. Okay. So the last part is when we have between L4, L5, all being held together, you know. So in this situation, a lot of affectation can happen. And in this side, you have almost all parts of the back, the thigh, and the perineum, depending on where the level of the lesion may be. So what this is telling us is you have a compression is covering both L3, L4, L5, S1. Do you understand? So it is a multiple level compression, and that compression, the patient can present with lower back pain, the thigh, the legs. In fact, even in the perineum, around the anus, the patient can be telling you there is pain. Okay? So, and then the sensation can be also at the thigh and the leg, as well as the feet, the perineum, which of course may be either bilateral or unilateral. There's variable paralysis or paresis, okay? And basically this affectation, whenever you have these multiple region, it also comes with saddle anesthesia, and then it can be a source of red flag. That is when the patient cannot be able to hold their urine, and they will have to go for a test. So here today is what we'll be discussing about our special test. And this special test, this cross-leg test, the Faber's test, the Kemp's test, the Trendelenburg's test. All these are various tests we're going to be seeing as we move. So, but before we go, I want us to, what is this? Okay. I want us to just have a short time where we'll just have a short lunch, and maybe by 2:30 we'll come back. Just 30-minute lunch, please. Is it 40 or 30 minutes? This is 2 o'clock. Okay. Please, let's have a lunch, and then by 2:30 we'll be back. Any question before we go now? Any question? We still have a lot to do in this slide, please. Any question? Shall we go for the lunch and come back?
I have a question, sir. Just hello.
Yes, sir. Let's have a lunch.
Oh, okay.
Go ahead. Michelle, go ahead. Ask your question.
All right, sir. It's just a clarification, sir.
Yes.
You may mention earlier from the earlier slide that anything low back pain is from the 12th rib to the gluteal region. So my question now is, can we now say Can we classify SIJ dysfunction or SIJ pain as a low back pain, or all these piriformis syndromes as a low back pain, or can we say a SIJ can have a refer pain to the low back? So that's the clarification I want to have, sir.
Yes. Beautiful. These are very important questions so that we remain on a good track and understanding. Like you mentioned, rightly said, SIJ is a different entity because it's a joint and a synovial joint on its own. It's just like saying the hip joint, the knee joint. So that's how you have an SIJ joint. The sacroiliac joint is also another synovial joint, but you know it has a very close relationship to low back. So an SIJ can also be a cause of your low back pain, or low back pain can also lead to sacroiliac joint dysfunction. Okay, so we because we have that classification between the 12th rib to the gluteal fold, you can see that we not specifically saying SIJ is part of the gluteal fold. It's also another entity on its own. And I hope very soon we're also going to take another course on SIJ only. Okay, so most times we have low back pain with also SIJ that is attributed to it. So we have to differentiate. That's not part of low back pain. SIJ is on its own, but sometimes it can mimic your low back pain. And secondly, you also have piriformis syndrome. Piriformis syndrome is also an inflammation of the sciatic nerve under where the piriformis muscle, don't forget, is a very tiny muscle that stabilizes the gluteus. So the sciatic nerve passes across the gluteus maximus as well as underneath the piriformis. So the sciatic nerve, as it passes, it can get inflamed between the piriformis muscle and that. So, and then that piriformis muscle will be what will be irritating the individual. So that also can mimic your back pain, because when you do the Faber's test, that's all the thing you are trying to exclude or rule out than your low back pain. And we're coming to see it when we are demonstrating the special test. Yes.
Thank you, sir. Thank you, sir.
All right. So any other further comments? I really want us to go have a short lunch. So after the lunch by 2:30, please let's be back so that we can finish up hopefully by 4:30 or 5. We still have about halfway of the slide that we need to cover. I don't know, I'm just going to skip slide so that we're going to demonstrating the practices we want to do. Okay. And so I'll see you guys in 30 minutes. Hello, can you hear me?
So I can hear you.
Okay, good. So I think let's just commence because we have a lot to discuss. I'm just going to share my slide and then we start from where we're supposed to continue. Yes, we talked after this slide, talking about how to identify the radicular pain coming from nerve root affectation, where you should point to the dermatoma supply, if there is any radiculopathy, where it should move to, and of course, if there is motor affectation, how you're going to identify all that. So now we're going into directly our special test. And I started by saying, what is the role of special tests in the evaluation of individual with non-specific low back pain? The first thing why we need to do the special test is that when we do special tests, it helps to support our hypothesis generation. What do we mean by hypothesis? We have a patient with low back pain. We want to hypothesize, is this pain related to a disc-related problem? Or it has to do with facet joint arthritis? Or does it have to come along a disc problem? So you want to see what hypothesis could affirm what you're treating. So it will help you generate this hypothesis. And of course, your special test will help you to differentiate between mechanical and neurological causes. You will be able to know if this back pain is more of a mechanical origin or it has some neurological involvement. Of course, when you do your special test, it helps to identify both the red, blue, and yellow flags. And of course, we say this special test should not just be a household name on its own. No, it should be integrated into a full comprehensive assessment package. Like we started earlier today, that will go from clocking the patient, evaluating and assessing the patient, and then looking at the impact of that thing on the patient in general. So you are not just coming to do only special tests and go. There are a lot of things you do before you come into special tests. So you have to integrate it. Now, I said the special test is categorized into these various patterns. Number one, you can have neurological tests just to rule out if there is or no neurological involvement, especially if we say there is a sciatic nerve involvement. So that you need to do some neurological tests for that. Of course, there's a joint mobility test where you want to check for range of motion of the spine. These are joint mobility tests. Of course, you want to see muscle flexibility and muscle power. All these, you have the assessment we're going to be doing. And of course, the pain provocation test, which will help you to identify, is this pain coming from the back, or is it the hip, or maybe somewhere like somebody mentioned the piriformis or something. So you'll be able to identify where the pain is rightly coming from. So these special tests could be part of, among them, you have the straight leg raise test, that is SLR, which is normally used to assess sciatic nerve involvement or nerve root compression. We said if it's a positive test, we'll be able to reproduce the pain along the sciatic nerve course. Of course, you have another one what you call the cross straight leg raise test. That is, it is SLR, but in the contralateral limb. So all these, we also use it to know it is similar to SLR, but it is performed on the unaffected leg. You know, if it comes up with symptoms on that side, it tries to tell you there is a disc involvement in this situation. But in a situation whereby both limbs are affected, what do? You don't need to do any cross leg test because both are affected. Among these tests, we're also going to see the favors test, which is joint involvement. So we're going to see it as we go. There's the CHEMS test. The CHEMS test is also called the quadrant test. It is used to evaluate the passage joint dysfunction or to ascertain neurogenic claudication. So we're going to see that. You also have the Trendelenburg test. The Trendelenburg is used to know if there is a weakness in one of the hip abductor muscles. So we'll see how that is done. We'll see that if it's positive, you see how one of the hip will drop. We also have the femoral test, which it normally assesses the nerve. It assesses for femoral nerve compression, and we want to see how it does. Usually, the patient lies supine, and the examiner extends the hip and knee while monitoring for pain or paresthesia in the anterior thigh. So now I want us to go into our activity. So I think we're just gonna use one of our models to see how this test will be done. So who is going to be modeling for us? Okay. We have imagining that this is a patient with a low back pain, and then we want to see how this pain is coming either from the disc or from the nerve root or other aspect of the body. Excuse me.
Please, I think your voice is reverberating or is echoing. I barely get what you are saying.
Read out the procedure. The first thing we want to use SLR, right? Is it SLR? In the slide, I've written how this should be performed. SLR, the patient is asked to lie supine. Please, can you lie on your back?
Can you moderate the slides from here?
The slides?
It's not when you give me
So we say the now the one is SLR. Is it SLR? Is it SLR? Let's hear. Please come close. The purpose of SLR is to
assess for sciatica.
We want to assess if there is a sciatic nerve involvement in the complaint of the patient saying he has low back pain. Now, the first thing we do is to do what? We ask the patient to or passive.
Passive.
SLR, is it supposed to be active by the patient or is it supposed to be passive?
Active.
What do you do? Please, somebody online. If you read my slide already, you will have captured it. I hope the people online can hear me. Can we hear?
Yeah. Yes, sir, we're with you, sir.
Can you hear me online?
Yes, sir.
Yes,
Yes, sir.
Yes, we can hear you.
We recognize now that SLR should be done.
We can't hear you anymore. We can't hear you anymore.
We can't hear you, sir.
Is an extension. Okay? So now SLR is supposed to go between 30 degrees and 70 degrees. Anything above 70 is no longer SLR. It is a hamstring stretch. You're just stretching the hamstring. Do you understand that? So it has to be 30 to 70 degrees. This is somewhere 70 degrees. So if you, assuming you lift your patient's limb between here to 70, and he tells you no pain, and then you go further and he said, no, now there is pain. This is not called a positive SLR. It's called stretching of the hamstring. So it means your patient has tightness of the hamstring, and that's why he's saying there's pain. Now, if you have ever met a patient with a real sciatic nerve involvement, the moment you want to start involving the sciatic nerve, the patient will shout. Will tell you, there's a pain, there's pain. Some of them will allow you to 30 degrees without pain, but the moment you want to go above 30, the pain starts. Do you understand? Now, any patient who does not allow you to be able to move beyond 30 degrees means the patient has a severe disc problem. I don't know if we're understanding it as well. It means it is a severe disc problem. That compression is severe, or rather, is very acute that it cannot allow him to move the limb. As long as you're able to go between 45 to 70, it means it's still bad. Do you understand? But if it goes beyond 70, it is a negative SLR. Don't write positive. Any pain complaint after 70 degrees is not positive SLR, it's negative. But there is hamstring tightness. Are we together? Now, this brings us to another thing. What is the difference between SLR and LASEK? I'm sure in your practice you have always talked about LASEK test. What's the difference?
Okay, LASEK test, you
Yes.
add another component.
Yes.
You dorsiflex the
You further dorsiflex the ankle. Who is with him in this thought? All the physical people agree with him. Let's see if the people online are also agree. Do we agree with this point of argument?
In LASEK test, you will include dorsiflexion of the ankle while doing the SLR.
Yes, for LASEK, you can also, I think, you might also even do cervical flexion to stress it.
Okay, class, can you hear me, please? Yes, please. No sound. They say there's no sound.
I can hear you now.
Can you hear me now?
Yes, sir, we can hear you now.
I was saying that do we really agree that in LASEC we need to add the dorsiflexion component?
Yes, sir. We need to add it.
Yes, sir.
Okay, let's see. Let's see my next slide. In the SLR, I said the purpose is to assess nerve root irritation, and we said the position that the patient is supine, the leg. It means is there's a possible disc herniation between L4 to S1. Perfect. Now, I said LASEC is the same as SLR. There's no difference. LASEC, the person who I would identify SLR is the man called LASEC. So LASEC test is used to assess static compromise. Hey, that's just the major things. Okay? Now there's something we call the Braggart sign. This is what you're trying to say when you talk about that LASEC will now go with dorsiflexion. It's called the Braggart sign. I'm sure we have not been hearing this in our clinic. Braggart sign means as you're trying to lower the leg slightly from the point of the pain, then you dorsiflex the ankle. If the radicular symptom returns, that is, it becomes, you know, patient tells you this is where the pain is. Sorry, let me go back here. When we move this way, the patient knows that there's pain. Yeah, this is between 30 to 70. So as I'm trying to bring the patient back down, I'm now dorsiflexing. When I'm dorsiflexing, it has come back. Are we together? So LASEC is the owner of SLR. So it's not when you put dorsiflexion that it becomes LASEC. It becomes Braggart when you put ankle dorsiflexion. All right, so that's number one. The next one we want to talk about is about the cross-leg test. The cross-leg test is just telling us if the patient is presenting with an ipsilateral pain on this side, which we have done our SLR. Now, the unaffected side, where he's not complaining, we are coming to repeat the SLR. If this one that is not complaining provoke another pain on that affected side, then the cross leg is forced. It indicates there is a real disc problem or compression of the sciatic nerve. That's what they call the cross leg test. They are coming to this side to do it because it's expected that this side does not really have any problem. So there is an ipsilateral issue. But if your radiculopathy or radiating pain is bilateral, is there a need for cross leg? In fact, you can't cross any leg. You understand? So it's just SLR we are going to do on both sides. Yes. So we also move to the next test, which is about the slump test. The slump test is used to identify any neural, that is nerve affectation in that patient with back pain. The patient sits and the hands are behind. Please, can you sit up? Just put your leg down. I need your hands to go this way. Yes, just hold it that way. And they said you will flex your neck, extend your knee, and dorsiflex the ankles. Most times we want both hands. Okay, what you're trying to do now is to put stress on any neural tissue between the cervical region to the lumbar region, as well as the sciatic where you move this. If this reproduces the pain, it means there is a nerve involvement in the patient. I hope this one is very simple. These are clear issues. Please relax. So, I said reproduction of symptoms that is relieved by neck extension. Now, when he does this, and this is a positive sign, but by the time he's doing extension of the neck and he says the symptom is going up, is a good indication that there is a nerve involvement. Okay? He said it suggests neural tension or reticulopathy. So that is it. So these are different images of slump test. Okay? We said the slump test was also developed by Lasek. Hey, Mr. Lasek is a Frenchman who lived in 1816 to 1883. He's a French physician. Okay? So he's the owner that did SLR as well as the slump test. We've talked about the cross leg, so we're going to Faber's test. The Faber's is just for us to assess if there is hip involvement or sacroiliac joint involvement in this patient. Okay? Assuming the patient, we're not sure if his low back pain is a pain all this region, you know, they will tell you as if it's still inside the hip. And in fact, some of them will walk like that. Okay? They're showing you as if there's a hip affectation. So what you need to do is a Faber's test. In Faber's test, you're going to put the limb where you're assessing will go into knee flexion, the way it is this way. And then the ankle is brought onto the thigh of the other limb. One of your palm is put on the knee of the flexed knee, while the other is at the hip. So when you try to do this, you're trying to find out if there is any reproduction of pain in the hip. Okay? So Faber's means flexion, this external rotation, right? And what? Abduction and then external rotation. Let's see what the procedure is saying. That the purpose for our Faber's test is to assess if there is a sacroiliac joint or hip joint affectation. The patient is put in supine and ankle on the opposite knee. That is the ankle of the limb you are testing is placed on the opposite knee. The assessor pressed down on the knee and the opposite anterior superior spine. I hope we get that. So he said a positive sign means there is going to be a pain in the groin or SI region. That is trying to tell you if it's positive, it's saying there is either a hip involvement or a sacroiliac joint involvement. And then that is the interpretation. You know that there's a pathology you need to now assess. Now, if you do your SLR and then it shows it's positive, the next thing you need to do is to bring it into this position where you have been able to do dorsiflexion, right? Abduction and external rotation in free position. So when you do this, you will now do the opposite movement into flexion, internal rotation, right? Adduction, adduction, and then internal rotation. This is going to identify specifically if it's in the hip, not the SIG. I don't know if we're understanding it this way. So please, these tests are very easy. Maybe Hajia will come and practice, because that's the essence of being on the physical ground. We mentioned the objective is to make sure that we learn some proficiency in doing these tests before we leave here today. Yes. Hajia, you want to practice? Or the other man? Yes, please come closer. We want you to demonstrate the Faber's test, which is a very simple test. All you need to do is to drop the ankle of the affected limb you are testing on the knee of the extended part, and then your hip, one of your palm is on the knee, and the other one is at the anterior superior iliac crest. Is it the crest or the spine? Whatever. So you do this. You see? So please. So you do it, and then we assume that it is possible. So what do you do for that? Good. So this is supposed to be Faber's. Usually what we do in our clinic day to day, when they say Faber's test, they do this while they are holding and they are shaking. This is what we normally do as Faber's, but that's wrong. It has to be kept here, and then there should be a gentle pressure between for SIG. Is that not? So that's why you are trying to repeat it. So if this patient tells us that he has pain around here, the next thing we do is the opposite of the abduction. Now we do the adduction. 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 You see, that's the reason why I say we have to practice. You see, really? Good. Now the patient is doing it himself now. And physiotherapist, you will become a more difficult patient for you now. You know, imagine if physiotherapy having back pain. You are going to suffer to treat that pain. So what we're asking you to do is, when you do the knee flexion, you're just going to rotate the patient. You know, this is the opposite of this. This is what we're doing as Faber's. So, but now we're doing internal rotation as well as adduction, not abduction, now adduction. You see? So by the time we do this, there is no way there is a hip pathology that the patient will not jump about. And the next thing is for you to ask the patient to go give you an X-ray of both hips. Don't ever do an X-ray of one hip. It has to be both hips so that you have something you're going to use for your comparison. Okay? So most time you're going to see a fractured neck of femur, or you're going to see, because most time when patient fracture the neck of femur, which is impacted, they will still ambulate. They will do. Because especially if it's not a huge impact, maybe due to reduced bone mineral density, patient want to sit down. They have fractured themselves in trying to sit down, they wouldn't know. You know, or somebody tried to sleep in the bedroom and she said, I heard something. The thing will have happened before you know. So most times they will have some little pain but move. So, but the moment you do that, there's no way to not provoke their pain. Do you understand? All right. Let's see. What next? Online, are we working together?
Yes, sir.
Yes, sir.
Yeah, we do, sir.
Good. So this is another test, what we call the CHEM test. The CHEM test is the quadrant test. It's usually used to test if the back pain has an origin of arthritis, facet joint arthritis. You know, I told you the facet joint is between the pedicles and lamina of each of the connective vertebrae. Now, that joint is a synovial joint. It means it can get arthritis. Do you understand? So, you want to be sure that is it coming from an arthritis problem, or it's coming from a disc problem, or it's coming from a nerve compression. So what you need to do in quadrant test, please stand up. The individual is meant to stand erect. You know, so we're not doing this in lying position or sitting position. Is in standing most of the time, going to more extension. You see that? Now in this extension, you also go to what? Lateral flexion and then rotation. You can see how much pressure we are putting on this patient. Because you're going to hold him, you know, you say he's a physiotherapist, so he has had everything. I say the guy is doing it himself. You know, but as normal patient, you ask the patient to be relaxed. So you will try to do extension. The moment you do extension, because a patient with a real problem in the back, he will get provoked with this. Now, apart from the provocation, you're still rotating the patient. And then you still give him some lateral flexion. Yeah, you see? So he said extend, rotate, and side bend. Plus an axial load. You know what is the axial load? This push. Do you get the point? So, the lady is asking us that if the patient is an old person, just like what Tumisha asked us earlier, it's an elderly patient. That do we want to allow the patient? You know, that do you want to break the patient in doing this? So it means you should use your discretion. It's not every patient you should do every test. Do you understand? So an elderly patient, how do you expect them to extend, rotate, and then move? Okay? And for an elderly person, you need to test for arthritis. Is it not there by default? It's already there. So please, we'll try to use our discretion most time in doing all these tests. All right. So this is an example of somebody doing the test. You can see how much stress the patient is going. So it provokes the symptom. They said localized pain, especially in the back, it shows that there is a facet joint irritation, which is arthritis most often. Now we also have the prone instability test. This is trying to test for the muscle flexibility and muscle path. Do you understand? In this patient, the patient is put in pro-line. Please lie prone. In this one too, you will ask, will you ask an elderly patient to do this? Yes. These are instability tests. It is first demonstrated by Sorensen in early 18-something. Okay, what he does is you move the patient down, go down, go down. The legs will be off the couch. Go down. Yes. Come on, maybe we should move our legs a bit. Okay. This will be bent up. Good. Now lie down. So your leg is going out as if you're standing to the floor. So just like that, relax your leg. You know, if this guy doesn't because the patient won't have, can you hold his leg like this? Relax your leg. Just relax. Say, come on, okay. So yeah, this is how the patient is expected to be. Okay? He is lying down, the legs are outside whatever. So we said you're going to put the legs off the table, and then a posterior anterior pressure is used before and after feet lift. So we just ask him, lift your leg up. Both. You see, now, if this patient can lift the leg up without any trouble here, it means he has back stability. Do you understand? You know, we could be thinking our patient don't have stability of the spine and all that. Now, if this patient lifts this and is not complaining of any pain here, it means he has good back stability. Lift your leg up. If you come here, come and touch here. Please come closer. Sorry, we are not going to expose your shirt. Relax your leg, go down. See, touch this. This is where you're looking for muscles of, what do you call them? Core stabilization muscle, right? Now lift it up. Put your hand there. See how firm it is. So, since the patient can do this without complaint of any pain reproduction, it means he has a stable spine. Okay, you can fight anywhere. So, online, do we get that? Or do we need to repeat it? That's one of the tests we use for stabilization.
Let's repeat it, sir.
What's the name of this test, sir?
Called the prone instability test.
Okay, sir.
So this is how you put the patient. The limb will be touching the ground. I hope you can see it properly like this. So what you ask the patient to do is to lift while you put a pressure open on the back here. So as long as the patient does this and there is no pain that is reproduced, it means the spine is stable.
Excuse me, sir.
Okay.
Please, what would be the indication for you to want to perform this test on a patient? Is it just low back pain?
Yes, when you feel that the patient does not have a good core stabilization. You know, if you remember, during the pathogenesis or pathophysiology of low back pain, it is mentioned that the back is being structured by three major systems. Number one is the body system, that is the vertebra. Okay, and number two is the muscular system, where you have the multifidus, the rectus abdominis, and all other core stabilizers. And then you have the nerve involvement. And they say if any of these aspects one is distorted, the triangular pyramid of stabilization of the back or core is distorted. So one of the commonest distortion is on the muscle, which is causing muscle instability. It's the reason why they establish core stability exercises. Now, before you put your patient to go through core stabilization exercise, you are supposed to demonstrate if they really have an instability of their core. So this test is one of the tests that you do to know if the core is stable or not. Are we there?
Yeah, thank you, sir.
All right. So we also try to rush. Where are we? Yes, full stability. That we see the SIJ stress test. The SIJ stress is just like what we perform with the favors, but most time we do the tie thrust of the femur. Okay. So normally what you do is you put the patient in supine, you flex the knee to 90 degrees, and the patient try to move your hand, because you're going to put a thrust, that is a force against his movement. Now push my hand up, 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 up. You see, push this way. So I'm going to be bringing it down. So if there is any SIJ involvement, it will begin to reproduce the pain at the SIJ region. I'm sure we didn't get this. What you need to do is put the limb where you are testing into flexion at 90 degrees. This is a 90-degree right angle triangle. Okay? And you ask the patient to lift the limb while you're trying to resist it. That's the force you are putting. In trying to resist this force, it's going to reproduce or provoke the SIJ. Do you understand? Yes. And of course, we can also do the SIJ compression test. In SIJ compression test, you put the patient into sideline. I didn't want us to go about the SIJ so much today, because I'm hoping sometime we should talk about SIJ alone. Okay? So I think I've skipped it in my slide. Let me rush to another slide. Repeated movement testing. Here is for you to be able to know where the patient is having more concern with his pain as regards movement. For instance, please lie on your back. We ask the patient, maybe for the first time, can you lift up your both legs? You know, in this case, we are also trying to see abdominal activation and back muscle. Most times, if the patient cannot hold it for more than 10 seconds, you know, there's poor endurance in this patient. I use that, you cannot hold it, look at this guy. So it tells you poor endurance is part of it. Now, you can ask the patient, bend your knee, just bend your knee, take it close to your chest, hold it to your hand. All these are preference. You're trying to see which movement will provoke the pain. So you can ask him, move it into this axilla. The patient can tell you this movement gives me pain. Or it tells you the other movement gives pain. Or it tells you, whenever I move it this way, it gives pain. So it is those movements that provokes the pain you are trying to see. Number two, you are trying to also find out what are the movements that give centralization of the pain. Centralization is a phenomenon in which if patients have back pain and the pain is or radiculopathy is going down, you're trying to do activities maybe at the upper side to see that that pain is returning to the central region. The more it comes up, the more centralization you are getting. You get my point. You'll be attacking or manipulating the patient in the lower, the lumbar region, and then the pain in this side, the patient will tell you is getting better, and then, but I'm feeling it here. That is a positive sign because it was formerly at the foot, but now it has moved close to the knee. So that is good news. Or it could be here, and now he's telling you the pain is in the thigh, is a good news. Or before it's at the thigh, and now he's telling you at the hip. Or from the hip, it tells you now my pain is worse in the back. That is a very, very positive sign. No matter how much the pain becomes, because you have been able to take away the peripheralization. Now you have centralized it. You can easily take it off. If you are treating a patient and the patient tells you, I don't feel anything here now, but my pain is more of my foot. Okay, you are doing wrong. That treatment is not working because you are peripheralizing the pain. You are causing more compression. Do you understand? You're supposed to do something that will move the pain upward to the origin of the pain, and there you can take it off. So, let's see, we said the repeated movement means, you know, this repeated movement, the interesting thing about it, please stand up, is the major reason of McKenzie therapy. McKenzie talks about positional and preferential movement. That there are movements that when you do often, it takes away your pain, it centralizes your pain. So, and that's why we ask the patient, touch your toes. And when I say touch your toes, I ask you, where's your pain now? The patient tells me, oh, my pain is leaving this side, it's coming up. What does that tell me? It means I should treat this patient more with what? Flexion exercises. But when I say touch your toes, and the patient said, oh, I'm not feeling the pain now in my back, it's now in my thigh. That's a bad sign. So you don't use that to treat the patient. And those are the things we're talking about repeated. Don't forget that in repeated movement, you don't do the movement only once. And that's why it's called repeated movement. It is a minimum of 5 to 10 times. When I say touch your toes, 1, you come back, you go, 2. So when you do it repeatedly, we now see what effect is it giving you. So if that effect is what we're looking for, then we'll do that movement more often. If it's a movement that is counterbalanced to what we want, we avoid the movement in totality. All right. Are we clear with that? Can we move further?
Yes, sir.
All right.
Sir, please, I have a question.
Yes, go ahead.
Okay, so based on Mackenzie, when you do the extension and it's in the movement that the patient feels centralization that you do your exercises. So initially, if the patient feels in extension and you do extension-based exercise, when the pain reduces,
Yes.
also impute flexion-based exercises so that it won't be like you're only exercising a particular muscle group.
Of course, that's how Mackenzie works.
Okay.
You use the first aspect to treat the patient to the full range, and then you begin to work on the other side to bring it back to complete movement. Otherwise, you're going to be inhibiting the other range of motion. Okay?
Thank you. Wanted to confirm.
So, we're talking about the active trunk movement. The active trunk movement is trying to assess the quality and range of motion. Like when we talk about our first patient we presented today, that we said she doesn't like to move. You know, the first thing we will realize that she's going to have reduced range of motion in her lumbar spine. So how do we know this? The first thing is to do active trunk movement. And that's what we call the Adams forward bending test. And the Adams forward test is the same thing I just said, touch your toes. You know, somebody who doesn't have this, or there's a tightness in any of the hip, the moment it's going down, you will see the patient going this way again. You see that there is no symmetry of movement, and there is no rhythm, as well as there's going to be reduced range of motion. Okay, so all these are things you can catch with active trunk movement, the quality of the movement, and then the range of motion. So sometimes the patient, instead of touching the toes, it will have to do a ladder with a tie. It means the patient goes like that, it goes one after the other, it goes, it cannot release the hand. Yes, that's what tells you that it's short move, because the patient goes like this with knee flexion. So it means he cannot extend. There are a lot of issues. Yes. So we said a positive sign of active trunk is for the patient to either demonstrate there is pain, or there is asymmetry of movement, or there is limited or reduction in range of motion. So that's for that. We also have the posture and gait observation. Usually this is to see if there are biomechanical components or contributors to how the patient is coming with the back pain. A patient who presents to your clinic with this, assuming as the patient is coming, you know, we say patient came in independently, well, without the use of support, but with a Trendelenburg's gait. Trendelenburg's gait means what? Something like that, right? This is how your patient will come into your clinic. So as they are coming, you're already observing. And that's why we physiotherapists, the moment we see a person, already our brain is just telling us what could be wrong with this guy. Where's the problem? How do we treat this person? You know, but while people outside were like, this guy, the guy is bouncing. Especially when you see somebody with torticollis, you know, for him, you know, those secondary school days, big boy, the guy is going like that. But for us, what we are seeing is that the guy has a ring. You know, somebody went like this. I know that you have a problem.
But the guy is feeling, you know, those footballers of Nigeria when are playing abroad, the moment you come back home, they call them senior man. Senior man. You know? So all these, while you are posing, we were seeing problem. Okay? So you begin to assess the patient by static observation as well as dynamic observation. While he's walking, you're trying to observe. And if he's standing, you're also trying to observe. Because you can quickly see a triangular side if patient is standing. Patient stand like this. Already you know there's a problem. Okay? Or a patient stand and he cannot stand without support. He will stay close to something. You know there's a problem. So all these are things we should look. We say we should be able to assess for asymmetry or abnormal movement. So we know that all this will have a functional impact on the back problem. All right. Do we have any other test you want us to demonstrate before we go to imaging? Don't forget, we have done our clacking, we have asked all the questions, and now we have been able to do some physical assessment to test our patient for both neurological involvement. We've been able to test for joint mobility. We've been able to test for neural tension, and then we were able to test for stability of the muscle. So we did all this. Now, we need modalities. Do we really need them or not to establish that this patient is having a non-specific low back pain or not? Do we need it? Having done all these tests, do we still need to do, because in our day-to-day clinical practice, the moment you just see the patient, go for X-ray. If you can do this comprehensive test, what is it that X-ray want to give you here? What is it? So you can see that as many times you are just increasing the cost of management to the patient. You know? Of course, patients will always want to force you because they will say, Mr. A has gone, I leave it there, the doctor wrote that. So we do want to visit with our doctor, we write, go and do that. After all, when the doctor requested for the test, he doesn't even know what to do with it. You are 90% sure that they are coming back with the spondylosis. What will you do with that? What information do you want to use to treat the patient based on spondylosis? But if you now assess your patient, you know there's range of motion, affectation, there's muscle instability. Don't you have so many things to treat your patient for? So we must please understand all this. Now, they say there are some imaging modalities that could be used in low back. So when you have a lot of conflicting issues, for instance, you tested the patient for hip pathology, you know, and then you find out that some of the test in the hip is positive, some are negative. You know it's possible, right? You can do some tests here, it's positive, some are negative. What do? You now send for an X-ray or a modality to just do what? To confirm and clarify the situation. So that you as the physician must have it at the back of your mind. What do you want to do with that test? Do you get my point? Now, if I'm treating a woman who can come to me with pain in the back, which I'm able to trace, and I feel this patient is likely going to be having a pelvic inflammatory disease, do you think I'll just go ahead and treat the patient like that? What would I do? What should I do? Online college, what should we do? What would have a woman, you know, of childbearing age, painted with back pain, and it shows that there is a likelihood of a PID. What should we do?
You send her for further tests.
Like what?
Like ultrasound.
Normally, a female in the physical said we should send her for ultrasound. What else should we send her?
For urinalysis.
If you send the patient for ultrasound, what do you want to do?
Urologist.
Hello.
Does ultrasound confirm PID? Huh?
There will be pelvic.
Where are the females in the group? Can ultrasound confirm PID? No, it doesn't. But of course, it's an inflammatory situation. It may see some other features there, but it's never a confirmatory test for a pelvic inflammatory disease. Because one of the commonest things that leads to PID is a simple toilet infection. So if we're looking at infection, can we see it on scan? We cannot see it on scan. Definitely, we'll ask the patient to go for what is called the HVS.
But I'll watch you.
It's called the HVS. What is HVS? Like people. You should not let them down.
I will come again. We didn't say there was interruption. Somebody.
Okay, I was saying that we're treating a woman, okay, and then the back pain is showing us there is also an involvement linking us to pelvic inflammatory disease. And I said, what should we do at that juncture? Somebody said we should go for an abdominopelvic scan. So, and I said, can a scan detect PID? I said the scan will only show that there are changes in those regions because a PID is primarily due to an infection. So since it is infection related, what do we do? I said we should go and do a test that is called HVS. And I'm asking you now, what is HVS? Anybody that Google, I will catch you.
Someone got in the chat
I'm
box.
sure they're asking Mr. Google.
High vaginal swab.
They have asked Google. This one, Google answer. Yeah? All right, that is a high vaginal swab. That is to go for an MCN. You use it to get microscopy, sensitivity, culture and sensitivity of which drug. So you can see that you don't really need some of those tests until and unless you know why you should do it.
Just to get down from that place now. You spoil that thing there. Just to get down.
I'll let this boy, the boy wants to learn physio, please let him understand what we're saying.
Start from there.
Yes.
Please, can you mute? Please, can you mute?
Physical is asking us, what sign would we see that will tell us this is likely a PID-related situation? Now, take a lady of 25 or 30 years that presents your clinic and tells you every test you do is positive. Every movement you do is positive. Is that likely to be a disc problem? Is that likely to be a generated problem? The patient tells you even at night if she wants to turn, it's painful. But she will tell you, if you press my back, I'm not feeling it though. Every compression test is negative. But if she wants to do any movement, especially cross leg or sit on the floor, you can imagine it's all pointing to where? At the pelvis. So that should resonate with you that there's a likelihood of a PID. Okay? The patient doesn't have to tell you that she sees some discoloration, she sees some changes. No, it could be that her inflammation, this is what is giving her. Okay? So these are some different situations. All right. So let's start with one of the first modality that we normally use is an X-ray. I said X-ray provide detailed images of only bony structure. Please, how many structures are there in the lower back? Are we supposed to be talking about the muscles, the ligaments, the nerve, the blood supply, arteries, veins, capillaries? I mean, but you chose only bone. And if the most time, if you are lucky, it's for the X-ray to come with spondylosis. If you are not lucky, the X-ray will tell you normal story. So what are you asking them to do? Don't forget, the person reporting the X-ray don't even know what you will do as a physiotherapist. Because you were only trained to serve a medical doctor. Yes. He was never trained to serve you. So until and unless we begin to see physiotherapists who are going into imaging, before they will begin to know that these are the kind of things physiotherapists are expecting when they X for X-ray or MRI. But most of their information is there to fit the medical doctor. So it can never help you in any way. So it means you must pay attention to what? Your physical examination and evaluation. Number two, you must learn as a necessity how to read the X-ray, not to read the report. Because those are the reasons why the medical doctor just depend on that report. He himself doesn't know how to read the X-ray. He just believes whatever that guy has said is what is happening. Now, as physiotherapists, are we supposed to treat the X-ray or treat the patient? Imagine you have an X-ray, he said it's spondylosis. So is it the X-ray we should be following, or we should see the patient and treat the patient? So please, let's not pay too much attention to the X-rays. Let's, number one, know the reason why you want to send for an X-ray. Do you understand? Basically, when you send for an X-ray, you want to assess if there are any degenerative changes in that spine. Especially, I'm treating a patient of 50, 60, or 70 years. I know there's degeneration. But how much? To what extent? To what degree? Is what I want to see. But I want to treat a patient of 25, 30 years with back. Am I expecting degeneration? Why should you send them? Okay? We want to see, is there any spinal malalignment in terms of scoliosis or whatever? And of course, scoliosis and kyphosis, you will see it straight in your patient. So we want to see, the major problem you should know with X-ray is that it does not show you anything about soft tissues. From muscle to the blood vessel, nothing will be shown. So it's all about the X-ray, all about the bones. Okay? Any question with that? The second imaging is what you call an MRI. That is the magnetic resonance imaging. This offers a high resolution image that can capture both the soft tissue, the blood vessels, as well as nerve and spinal cord. You can really see where the problem is coming. It is the ideal diagnostic tool to confirm your disc protrusion. Don't forget, disc disease is categorized into 5. Of course, there's a disc disease. So you want to know, is it just a bulge? You know disc bulging, right? Just the disc to bulge. It means there is no any interaction between the nucleus pulposus and the annulus fibrosus with the environment. That is the nerve root region. But there is what? Swelling, bulging. There's a pressure coming on that disc. That's the first level of affectation you're going to see. Then there's what we call the disc protrusion. The disc is beginning to break the annulus fibrosus, which is the outer covering, is beginning to tear, where you will see the nucleus pulposus beginning to show out. You know, is protruding. Now, from the level of protrusion, we take you to the third level of affectation. We call it disc extrusion. That the disc matter has poured outside. So you are only going to be lucky if it's not pouring on your nerve roots. Or you can see it pour on the nerve roots, but it is what they call it is already desensitized. And this is the reason why you will not take every patient because the MRI shows compression or this problem. Sorry, don't worry. You will not show because the patient has this problem that the patient is must be treated. There are patients that have 90% or 100% positivity with their MRIs, but they are asymptomatic. Will you say, come here, I will have to treat you? But you will go to another patient, the MRI is clean, but he has the whole symptoms with nerve contraction, what will you do? I'll go home, there is nothing wrong with you. So it means we are not supposed to treat all those images, rather, we should treat the patient. So we use this thing to confirm most of the complaints of the patient, especially when there are regional situations of ambiguity, things that are not clear. Okay? Now I have an image here that is telling us about the recommendation, what we should choose instead of the other. Okay, you jumped one slide. Okay, they said MRI is non-invasive but can be very costly. So we also have the CT scan. The CT scan, as we all know, is computer tomography. It's used to only have the 3D image of a bone. That is your bone from every angle. So it can give you clarity like if you have a fracture on that bone, or you have facet joint arthritis. So all those things it can capture, but it does not show you beyond the bone. You understand? So it involves some radiation. So that's why we don't put it often for patient. You understand? Unlike MRI, this bone CT is like doing 100 X-rays. One CT is like going through X-ray 100 times.
I mean, at the what is
let's look at this table. The table is trying to show us what type of imaging modality should we request or recommend when there is a particular symptom or sign. Okay? They said, if the patient has radiculopathy, what will the X-ray do for you? They said, please don't recommend X-ray. Do you understand? They said, you can ask for CT if MRI is contraindicated or is too cost for the patient. Okay? So in the CT, you do what they call the myelography. Myelography means it's an X-ray, but with dye. What they call dye, they inject what do you call it? A contrast. Okay, so it's an X-ray, but under the guide of a contrast. So now it makes it invasive. So and then that contrast can also react to some patient. So that's why it's also. They said MRI is the ideal when you have radiculopathy. Okay, even the bone CT and other type of PET CT scan are all not recommended. So, but when you have issues like cancer, they will ask you to do a bone scan or a PET scan. Sometimes you have to do an MRI as well. So I've given you all those things you should try to learn from this table. What type of recommendations you should use. All right. So I say myelography involves injecting a contrast dye into the spinal canal and taking an X-ray. It's an old form, and usually it has been replaced by MRI. You have the bone CT. We have mentioned detect area of the bone metabolism. And then it is less specific than other modalities. We cannot really tell you where the problem is. Ultrasound is usually for soft tissues such as muscle and ligament. It can help, but it has limited range of penetration. You also have discography, where you put a dye into the intervertebral disc and then you go for an X-ray. You have a lot of them. There's fluoroscopy, nuclear machine imaging, functional MRI, and so on and so forth. I said the choice of an imaging modality, the low back pain, depends on one, what is the suspected diagnosis that you're looking for? It will tell you what type of X-ray or what type of imaging you should go and do. What is the clinical presentation of the patient? That's what should tell you what you should do. Then there is a need for detailed anatomical or functional information. You must have good information before you send it. I said some physicians use a combination of all these modalities to do it. Okay, so this is our last part. We are now going to our group work. So we're going to use the next 20 to 30 minutes to relate to this situation. So please, online, you're going to group yourself into maybe 3 or 4 groups, as usual. How do you want to make our groups? You can remove your camera. Any question before we go there? Do you have any question?
Yes, there's a question, sir.
Okay, go ahead.
Question, sir.
Go ahead.
If the patient is
your mic.
suspected to have
Yes.
if a patient is suspected to have spondylolisthesis, and we are trying to avoid sending the patient for an X-ray. So, are there clear signs or tests that can confirm there is a listhesis, a shift in one of the vertebral bodies?
Yes. The first thing you need to know is that when you see that the lordosis of a patient is accentuated or exaggerated, it's a sign to tell you that there is either a shift, okay, or an instability of a spine. And that is an indication that you should not do any movement therapy or movement assessment until you confirm. So with those patients that you're suspecting spondylolisthesis, please, you should go for an X-ray. That's the first thing to do to confirm. There is no clinical test that will confirm a shift, you know, of a vertebra over the other. So we confirm that on an X-ray. Are we there?
Yes, sir.
You can hear me.
Yes.
So the person that asked the question, did you get my response?
Yes, I got it, sir. Thank you.
All right. So I want you to be in 4 groups. So just at random, just choose whether you're in group 1 or group 2, 3, or 4. So we're going to make some discussion after we see the slide. Now the case study is telling us that okay, I'm not slide is not shared.
Okay, so
Let's keep my slide down.
Okay.
Are we there? Hello, are we at this slide? The case study. Okay, we are looking at a patient, Mr. John, who is 38 years old office worker. His chief complaint is that he has low back pain. And this pain, he reports he has been experiencing the pain for the past 6 months. The clinical history indicates that John works as a desk job that involves long hours of sitting and computer work. He doesn't have a history of previous low back pain or major spinal issue. He reports a gradual onset of pain, which initially began as a mild discomfort and progressively worsened over time. John mentioned that his pain is primarily localized in the lower back, but occasionally radiates into his right buttock and thigh. His clinical presentation, John described his pain as a constant, dull ache in the lower back, and is exacerbated by prolonged sitting, but relieved by lying down. He also experiences occasional episodes of sharp sitting pain down his right leg, particularly when he stands up after sitting for an extended period of time. On physical examination, John exhibits a slight loss of lumbar lordosis and increased muscle tension in the paraspinal muscles. SLR test is positive on the right side, producing the leg pain below the knee. Reflexes and sensory function appear normal. No red flags are identified during the assessment. So these are the discussions. For group 1, we want them to discuss potential causes of John's low back pain, including the MS musculoskeletal situation, neuropathic, and other factors. For the group 2, we want you to examine the absence of red flags and the significance of ruling out serious underlying condition. Number 3, which are group 3, we want you to explore how John's sedentary work environment, prolonged sitting, and poor ergonomics may be contributing to his pain. And then for group 4, we want you to debate the necessity of imaging to evaluate the source of the symptom further. All right. So how are we going to take it? So, who are those in group 1 that want to discuss the potential causes? I hope they can hear me.
Yes.
Okay. Yes, please. Somebody in group one. We need to, okay, do I give you some few moments to interact and discuss? Colleagues. What is the way forward? What's happening? We don't want to participate.
So, hello, sir.
Yes, please, go ahead.
Okay, sir. So from this scenario, I can see that John has a kind of job that makes him to sleep for a prolonged period of time, and that
Which
could
group are you speaking for? Is it
for
group
group
one?
one, group one, yes,
Okay, fine, go ahead.
and that could predispose him to coming down with a sleep disk. And as we can see that this SLR test was positive, so that's pointing to a um a compression of the sciatic nerve roots, leading to a radicular pain. And yeah, so that's what I can actually say here.
So what you have just mentioned, are you telling us it's a mechanical contributor or is a neuropathic contributor to the pain of John?
Yes, I feel it's a mechanical contributor, so it's more of a musculoskeletal issue.
I was of the opinion that it's a neuropathy because you made mention of nerve compression.
Okay, I would say there's an interplay of, there's a neuropathic issue because there was an involvement of, there was a nerve compression, so
And when you say there is a nerve compression, it means you're going to have issues with the muscles. The muscles are not going to be functioning very well. And that's where your MSK comes in.
exactly. So I was going to say it's an interplay between the musculoskeletal and, it's more like a musculoskeletal and neuropathic involvement.
It's not only that. Now, when you are not functioning, the muscles are not functioning well, what's going to cause the patient is that there's going to be poor muscle power, leading to what? Fatigue and less endurance of the muscle, and then the patient will be put into sedentarism. Okay? Now, the sedentary lifestyle can predispose the patient to other comorbidities that we have mentioned earlier this morning. So those are the potential causes we're talking about. I hope you're following me. Emmanuel, are you with me? Okay. Let's move to group 2. Does somebody want to make any response to group 2 question? Yes, any person? Ademiwa, are you there?
I was one that
Okay, there's one that just finished responding to group 1. Okay, thank you. Where is Esther? I don't know why everybody don't want to talk. Is it that we didn't understand what we've been discussing today or what? Hello, somebody should say something. It's meant for us to interact. This question is meant for me to know if you have been participating, and then are you finding it easy to comprehend, or we have some challenges where we need to clarify. So please, people should feel free to open up and discuss. Fatima, I mean, maybe I should just be calling our name so that we can participate. Fatima, you need to speak out. If my old therapists are also in the group, but they don't want to talk. You don't want us to learn from what you're experiencing. Fatima, which one? Eh? You know, I know that you have been practicing for over 12 years now. Where's what's her name? Karima Sadio. All of you don't want to talk.
We are here. We are here.
Yeah, so please, somebody speak up for me too.
Sorry, your voice is echoing. I can't get you clearly.
Can you hear me now?
Yes, it's clearer.
Yes, I said if we look at the slide, group 2 wants us to examine the absence of red flags and the significance of ruling out any serious pathology from Mr. John's case. So, how do we examine the absence of red flags from the case presentation? Let me take you back to the clinical physical examination. In the physical examination, the last one said no red flags were identified during the assessment. So how did we come to that?
Sorry, so when we are assessing for red flags, most of the time is the subjective examination that can give us an indication. So you want to know, does the patient have his pattern of pain? Does the patient have associated symptoms that can be a sign of red flags, such as does the patient have night sweat? Is the pain a type of pain that doesn't respond to any form of movement? It's constant, irrespective of this position. Is the pain associated? Does it have a fever, or does it have a history of infection prior to the pain? And does it have weight loss or those type of questions? It's important for us to have those questions so that we can rule out any serious pathology that can be indicative of further referral.
Exactly. Thank you so much, Esther. And that's why I've been calling your attention. Yeah, actually, that's what the red flag should be all about. Identifying any pathology that will require immediate referral to other specialists. So this patient, Mr. John's case, we did not identify any red flags. And therefore, the patient was referred directly to continue his physiotherapy. Okay, let's see the third question for group 3. Group 3 says we should be able to explore how John's sedentary work environment
Yes, we can hear you, sir.
Right. So please let's look at this last aspect and see how we can respond to it. We say Mr. John is more or less an office worker who sits for a long time and he doesn't do any other activity. Okay? So we want you to tell us how his work environment, the prolonged sitting, and poor economics may contribute to his low back pain. Any person? We're having just 10 minutes to round up.
Oh, yes, sir.
Go ahead.
Prolonged sitting could contribute to low back pain, sleep disc, as you know, assuming prolonged sitting for over the course of time could lead to, putting pressure on the spine, particularly the lumbar spine, and that could culminate in disc degeneration and herniation over time.
That's cool. So what about the work environment?
Oh yes, Mr. John needs to learn to avoid being sedentary at work. So he needs to learn to move at intervals between work.
So how do we discuss this with Mr. John?
Because being sedentary, sitting around for long could, like I already said before, could predispose him to coming down with a sleep disc. You know, he's sitting down for long put pressure on the spine, particularly the lumbar spine. So that could lead to degeneration over the course of time.
Exactly. So we know that the sedentary type of work is also putting all his muscles into disuse, and therefore these muscles will have to build up fatigue over time. So any little activity will precipitate or predispose them more pain. So this is why often it's going to cause more problem for the patient than good. So the patient needs to be as active as possible. Anyway, we've been able to identify and show us some of these reasons so that when we see our patients like this, we have the opportunity to explore and find out their work environment, how they see, the type of chairs they use, desk and table height. So we assess for both home and office ergonomics to be sure that it's not what is causing the present situation or adding to the risk of the problem at hand. So as a last discussion, I want us to debate for Mr. John's case. Does he have a necessity of imaging to identify his problem or not? Yes, this is meant for the whole class. I want us to agree on this. Does Mr. John need maybe an X-ray or MRI or CT scan or whatever? If you do agree he needs it, please show us and give us a reason. And if he doesn't need it, tell us and give us a reason.
Okay, sir. Please, can you go back to the physical examination? We'll speak for group 4.
Okay, good. So on physical examination, we say John exhibits a slight loss of lumbar lordosis and increased muscle tension in the paraspinal muscle. SLR was positive on the right side, producing the leg pain below the knee. The reflexes and sensory functions are normal. There were no red flags identified. So, do we need any imaging? If we do, what type and why? Because Mr. John is a classical case that comes to our department every now and then for physiotherapy. Don't forget, Mr. John's case is chronic. It has been there for the past 6 months. So this is our type of classical scenario that we see in our day-to-day clinic.
Based on what I see from the physical examination, Mr. John may not likely the presentation, sir. Can I see the presentation? Is it like you made mention something of like 3 months?
I said John described his pain as a constant pain to the lower back. It is exacerbated by prolonged what will express expressional episode of sharp shooting pain down the leg, particularly when the time of attacking the low time.
So based on this, actually, I will say John may likely benefit from MRI The reason why I said MRI.
Yes, why?
Pardon?
I said, why?
Yes. He may likely benefit from MRI because, like you made mention earlier during the presentation, that the X-ray only captured the bones, which he said while the pain, he experienced the pain and goes down below the knee. So if he can do so that you can see the other structure, the soft tissue within the back, if there is anything that, but that doesn't mean he must do it. But if it affects, he can do so to some degree. He can benefit from it, sir, to some degree.
After the day, you can see that the way your name is not arranged, the way you are giving explanation. You are telling us to agree and you don't agree and do that. Yes?
No, sir. What I said, sir.
The question, do we need any of these imaging techniques or not?
Yes, sir. We can use the MRI because the MRI will give more detailed information about the back, which will capture the bones, the soft tissue, so that to see how it is, the state of how it is, the back.
That's fine.
Pardon? I say the back, sir, the lower back.
Okay, sir, I want to give my own in. I want to say, can I say
Why?
Okay, great. So for this patient, I will not, in the initial phase, recommend any scan because from the examination and presentation, there's nothing indicative yet. This seems like a non-specific low back pain. So I will initially start my management. But if after 6 to 8 weeks of my management, patient has no improvement and the pain is still persisting or increasing, then I will have to recommend for a scan and preferably an MRI scan.
All right, thank you so much. That's why also basic. Yes, any other questions? Do we really agree that they need an imaging modality for back or not?
Good evening. Yes, sir. Yes, my contribution, I will quite disagree with the first speaker who said we need MRI. Now, looking at the age of this patient, is 38 years old. Then other evaluation rule out red flags. So then the work environment made us to understand that he has there's prolonged sitting, is sedentary kind of because of this of his work environment. So there's nothing that is pointing to refine this patient for a scan or MRI or whatever. So the goal of the therapist is to.
Your point is very loud
Yes.
and clear. And that's why.
Yes, sir. Yes, sir. That's right.
Any other person? We have like 2 minutes to disseminate these information. So, if there are no other contributors, I'm going to make it clear that based on the presentation of this patient, going clinical history, clinical presentation, as well as physical examination, I don't think and I don't see any reason why this patient is sending for any imaging modality. Number one, you can't send your patient for any imaging modality said we must establish
Please, sir, your voice is echoing. We can't hear you. Your voice is echoing.
what happened somebody to write down.
Let me check.
Please check. I think Can you hear me now?
Yes, sir.
It's audible now? Okay.
Yes, sir.
All right.
Yes.
So I was trying to make the comment that before we make any request for an imaging, the first thing we will do is to we have the reason why we are requesting for the imaging. So if there are no reasons, then it means there is no point to do the imaging. Number two, we have to be sure that if we do an imaging, it's likely going to change our goal of treatment or our treatment plan. If the treatment plan is going to remain unchanged, then there's no point doing the MRI and not doing any modality or imaging modality. So we have to ensure that these two factors are covered before we request for any type of imaging. So if we look at the case of Mr. John, you realize that Mr. John has told us that his major concern that is the pain that is dull, is constant and dull ache in his lower back. And this pain is usually exacerbated by sitting. If you sit for a long time, the pain will be there. But the moment he stands up and moves around, his pain will, the moment he lies down, the pain will be relieved. It means there's a positional relationship between the pain and the situation. So therefore, it is that situation we will need to hammer upon to make sure that we get what happens when we sit down. It means the compression of that gives pain is usually in that. So the first thing is to go and assess, is it the chair that is faulty? Or two, it is the prolonged sitting. So if it's the chair that is faulty, you just change the chair and make it a more ergonomic fitted seat, or you adjust the chair. So that will take care of the problem. Secondly, if it's a prolonged sitting that is causing it, you make sure that you advise and educate the patient on what? On consistent intermittent break in sitting. So all these will take care of the problem. Why are you going for MRI? Or why are you going like this? Is it going to change this plan? If it's not going to change this plan, then there is no need. Secondly, we say, why are we looking for the X-ray? What do we want to look for? The patient told us that One of the issues he has that the issue concerning the physical examination. So the major issue, like I was saying, is the physical examination will show that he doesn't require any issue that differs from what the patient used to know. So therefore, it's not likely going to benefit from change of any of this activity that we're talking about. So we just need to ensure that the patient is taught how to be more active and what to do much more for himself. And the last note, we want to be sure that the patient will require only the treatment that will take care of the present situation with or without the imaging. So if that imaging will not change the course of treatment, then the patient doesn't need it. If the treatment is likely going to change, based on what we are looking for in the MRI, then we will do an imaging. Now, this expert mentioned that during if you treat a patient for 36 cases and the patient doesn't seem to be better, that she will not request for an MRI. But usually, you will find out the patient is not doing well. It doesn't mean that he requires an X-ray or MRI, that's why he's not doing well. If you are giving a treatment that doesn't tally with the problem the patient is having, you don't expect the patient to be well. So if you identify that the patient is having sedentary lifestyle and is a cause or a contributing factor to pain, and you did not address that cause, how do you expect the patient to be well? That's because you have been doing your treatment and the patient is not well. So you must find your treatment that it means maybe you have not been treating. Just know why you are requesting for the debate and know that debating is actually change the treatment protocol. Now, somebody is asking online that if two prerequisites for qualifying for X-ray, okay, that is mentioned today. The first one is if you take the X-ray or whatever modality you are requesting, you must know its functionality. That is, also, why do you need, what do you want to use it for? You know, what do you want to establish from asking for an MRI or asking for an X-ray? You must know that imaging, you must know how to read it, you must know how to interpret it.
Yeah, we can hear you. Like it's breaking. The voice is too low.
Can you hear me like this?
Yes, sir, but it's a bit low.
Can you type it in the chat box? They want the two factors before you request for any modality. And they say they can hear me. Can you hear me now? Can you hear me? No. The internet mic. Okay. So if you can hear me now, I'm trying to say that there are two factors which we must have at the back of our mind before we request for any imaging modality. The first factor is we must identify why do we need that imaging we are requesting for. Number two, we must identify that how do you interpret that imaging? You must know how to do the interpretation of that imaging before you request for it. Then you must now understand that the imaging you are requesting for, you can only do it if you know it's going to change your plan of treatment. If that imaging, with or without it, your treatment plan will remain the same, then there is no point asking for the imaging. I don't know if this clarifies it.
Yes, sir, it has. It has cleared the air. Thank you, sir.
All right, thank you very much. Actually, it has been quite challenging for us today. I don't know, there is a bit challenging for us today. I don't know, there's a bit of weather issue attached. There is likelihood of rain today. So, really sorry for the technological glitches, but we hope to have better connectivity in our subsequent sessions. We hope to stop at 4:30, and it's about 10 minutes or 11 minutes beyond time. So please, if except we have any other questions we want to ask now, I want us to allow every colleague to go and rest. It has been a very long day. So please, any question? Yes, somebody just sent to the WhatsApp, the chat group, that the patient doesn't need imaging, rather he needs education on taking intermittent break and ergonomic safety at work. Beautiful. That is all what we've been talking about, and we appreciate you for your contribution. Thank you so much. Yes. Any other observation, contributions, or questions? Colleagues, can you also advise us what do we do to make it much better in our subsequent sessions? And then where do we go to from here? Are we happy with the package of what we are having? Is it worth the money we are paying for? Or we feel we have been surcharged? What's your take home?
Yeah, the package is rich and the lecture is well executed and interesting as well. Very interactive. I have learned a lot.
Okay, thank you so much. It's quite important to get the feedback. That's the motivation to do more. Yes. Any other
comments, questions, observations? Yes, somebody said they will be happy to have the slide. The host is going to share the slide with you. All right. Having had the whole day, I want to thank colleagues for making this a reality. We hope to come up with some more interesting sessions, hopefully SIJ next time. And then perhaps we'll also begin to go to the neck and then other parts of the body as we move. So I thank you for participating, and I look forward to see you in subsequent programs. Have a wonderful evening. Thank you so much.
Thank you so much, Prof.
Thank you, Prof.
Oh,